see my screen?
Not as yet.
Not yet. Just give me a second. Share screen. Sorry, it's taking a bit of time. I don't know why it's getting so much of a basic problem. Apologies, guys. I'm just struggling to get my screen on. Share screen. Doesn't seem to give me the option to share screen. Share computer. Oh, God, Lord.
Rohit, can you assist Dr. Ajay Sinha?
I don't know for some reason. Okay, it doesn't give me the share.
Has somebody shared the screen already?
No, sir.
No? Okay. Share screen. Okay, hang on. We should be able to do it now. PowerPoint. Hang on. Files.
Girish Solanki seems to be having the same problem. He says he can't see the controls. Is there a UK problem to see the bottom of your apples?
I sent faculty
I
links.
just shared it a short while ago. I don't know why it's not giving me the option to share. Hang on.
I can see the panel share screen. Can you see the share screen, Ajay?
I can see the share screen, but it doesn't give me the option to bring the talk on. Hang on. Documents.
You go to the share screen and then have you got your talk minimized?
I have my talk minimized, yes.
Now just go to the share screen and get to your desktop or your laptop screen.
Okay. Share screen. It's just, hang on. I've got my talk minimized, share screen, and then
Can you see your talk?
I can't see my talk coming up there.
You need to open your presentation. If it is minimized, it won't come up. You have to keep it open and then share screen.
Okay, just hang on. Just go back and do it. Give me a second. Sorry about that. I just did it a minute ago, and then
Open the presentation, so don't minimize it.
yes, okay. That's what I'm gonna do now. Give me a second. Come on.
Rohit, can you please assist Dr. Ajay?
Give me a second. It should be here. Actually, my computer is suddenly decided to pay funny.
Please rejoin again, sir.
Give me a minute.
Dr. Ajay, if you permit, should I ask Dr. Ramesh Sharma to?
Yes, please. If you don't mind. Sorry. Just give me 1 second. One minute. I've got it now. I think you should be able to get it in. I think it's there. Okay, let's see if I can get it now. Give me a second. Share screen. Share. It doesn't give me the option to share it at all. Share files. I'm sorry, guys. You need to have to get somebody else to do it first. For some reason, it doesn't give me the option to share. It doesn't get me up.
Sir,
Why don't you just log out and log in?
yes, sir, you can do that thing. You can log off and you can connect it again, sir, because sometimes such kind of issue can happen, sir.
Okay, sorry about that. Because I checked.
That's okay. So I think we'll go ahead. If is Dr. Ramesh Sharma ready with his talk?
Yeah, I am okay. You tell
Okay.
me, I can go ahead.
So we'll now invite Professor Dr. Ramesh Sharma. He will speak on management of a child with Cruzen syndrome. He is a professor and head of Department of Plastic Surgery in PGI Chandigarh and a renowned figure in the entire country with expertise on craniofacial surgeries. Professor Dr. Ramesh.
So are you able to see my screen,
Yes,
please?
yes. Please go ahead.
Okay. So thank you, Dr. Deepak, for giving me an opportunity to share our work on such an important platform of pediatric neurosurgeons. The Cruzen syndrome is one of the commonest syndromes which is seen in non-syndromic variety of craniosynostosis. And in the last 20 odd years, since when we have been performing operations on craniosynostosis in our institute, out of 169 patients which we have operated, 21 patients belong to Cruzen syndrome. This makes it about 13%. And so the Cruzen syndrome, we will recall, has multi-sutural involvement, as happens in any syndromic patient. And in about 95% of the cases, it is the coronal suture which is always involved, so thereby leading to brachycephaly. And there is associated mid-face hypoplasia, which becomes worsened over a period of time. These patients are also characterized by marked proptosis. Interestingly, there is no mental retardation in these patients, and I would like to dwell upon this respiratory distress later in my presentation. So this is a typical patient of Cruzen syndrome, and we find that there is marked proptosis, there is supraorbital recession, and there is marked brachycephaly, because, as I said, it is the coronal suture which is involved. And now, when we have a look at their pathology, we find that generally it is a multi-sutural involvement. And the very fact that they have marked proptosis is because of the fact that there is shallow orbital sockets. And these are shallow because the anterior cranial fossa as such is very small, so the orbital roof is very small, and the posterior wall of the orbit is displaced anteriorly. So it makes the orbit look very small and leads to proptosis, which can be so severe that the patients can have subluxation of the globe happening quite frequently. And then there is, of course, a marked mid-face hypoplasia, which is seen in this CT scan here also. And more importantly, because there is marked mid-face hypoplasia, there is narrowing of the nasopharyngeal airway, and these patients are prone to, and also invariably these patients have got deviated nasal septum. All this complicates the respiratory effort of these patients, and they are prone to having chronic infections, and this can lead to a chronic respiratory distress kind of situation. So the protocol for operating for managing these patients is that we get the patients referred from either our pediatric medicine or genetic clinics. Sometimes we get direct referrals from the other hospitals, and we plan them in a combined team under one roof, which includes pediatrician, neurosurgeon, oral surgeons, and pediatric anesthetist. Fortunately, we have all these super specialists available at our hospital. And we also get useful input from ENT colleagues. And we also refer these patients to sleep lab whenever there is a need. The age of surgery is around 1 year, or if the patient comes a little late to us, then we can't help it. But generally, we try to operate upon them by the age they are 1.5 years. The surgical procedure are generally, at least 2 surgeries are needed. In first surgery, we do frontoorbital advancement and do some kind of expansion cranioplasty. And at a later date, we follow them up in the outpatient. And if we find that the mid-phase hypoplasia is resulting in a lot of difficulties, then we think of doing distraction at Li-4-3 level in all these patients. They are watched for various parameters in the growth lab, and we keep on continuously looking at their cranial indexes. And in the meantime, we also get their regular ophthalmology checkups. Interestingly, out of these 21 patients, only one patient we could have signs suggestive of raised intracranial pressure, for which our neurosurgeons had to do some kind of drainage procedure. We also get all these patients assessed by our psychologist. And generally, if there is no other compelling reason to do the distraction early, we wait till about the child is about 5 to 6 years of age. So let me present some of the case studies. So this is a typical patient, which I showed in the earlier slide also, with the craniosynostosis with Cruzen syndrome. He is aged around 1.5 years. So he underwent frontoorbital advancement after taking out the frontoorbital segment and then rearranging the calvarial segment in such a way that we are able to expand the cranium in the longitudinal direction, anteroposterior direction. And this is how the child looks after about 6 months of the surgery. In these 6 months also, there has been persistent increase in the hypoplasia. We can notice that it is increasing, and this is becoming quite pronounced as the child was growing in years. The parents also complained that the child snores a lot. This was one of our earlier children where we had managed the patient, and so we kept on waiting so that the child has enough growth of the skeleton so that we can do distraction. But as we were waiting, the child started having recurrent episodes of respiratory infection, and he once landed up with acute respiratory distress and had to be intubated. So this was the time when he was around 12.5 years of age that we had decided that now we should go in and do his distraction at Li-4-3 level. And so this is how he looks like after Li-4-3 level distraction. And so there is advancement of the mid phase. And interestingly, if you have a look at the airways, the airway is now reasonably expanded, and the child doesn't have any further episodes of respiratory distress, and his snoring has altogether disappeared. So, we gained experience that whenever we have marked hypoplasia in these children, we should try to do the distraction as early as possible, because if we wait long enough, then they can go into respiratory distress, as one of this patient, the previous patient went. So this child was operated at the age of 1 year. Expansion, cranioplasty, and frontoorbital advancement has been planned and executed. And this is her after about 1 year. And again, there is hypoplasia, but still the parents were quite happy that she was not having any episodes of snoring or infections. So we wanted to wait till the child became, now this is how she looks like at about 3 years of age. Still, there was no pressing reason to go ahead for distraction. But around 5 years of age, keeping in mind our previous experience with the first patient, we thought that now she is big enough, and probably she will understand that if we are putting an external device, she will be able to cooperate. And cooperation was quite well from this child. And we were able to distract her once again at the Li-4-3 level. And we kept her on reverse face mask to maintain the distraction which we had achieved for about 1 year. And this is how she looks like 1 year post-op after distraction. Another patient where again we were we decided that we should do a distraction because this child was also showing signs of mid-face hypoplasia, although it was not something very urgent. So we decided to distract his mid-face at LeFort-3 level, and this is how he looks like at age 10 and at age 13. The distraction did improve his facial profile, and he has no issues with his breathing. Another case who was operated quite early, and then she also, we did her distraction while she was about 10 years of age, and this is how she looks at the age of 13 years. You will appreciate that the mid-face hypoplasia is no longer noticeable, and her facial profile is quite near normal. We had this patient, very interesting patient, and this is one of the patients which came to me when I had started this facility in our hospital way back in 1995. So we had done her frontoorbital advancement when she was 16 years of age. And this is, at that time also, we noted that there was mid-face hypoplasia. But since this was quite early and we didn't have any mid-face distractors with us, so we were waiting to get some kind of, equipment so that we are able to distract her. And so we were able to fabricate something from our local resources. And so we thought of preparing her for distraction at LeFort-3 level. And this is her appearance after our orthodontics have done the decompensation. And now she is ready for distraction at the LeFort-3 level. And this is how she looked like just before the distraction. And this is the appearance with our indigenously, manufactured, designed distractor. And we did her distraction. And this is the 3D CT scan post distraction. There was forward movement of maxilla as well as the orbits. And this is how she looks 2 years post-operative. So all these examples can, safely allow me to come to some conclusions that the majority of these patients of Cruzen syndrome have brachycephaly as the presenting feature. And all of them have proptosis of varying degrees. And as has been reported in literature, that if they have recurrent episodes of respiratory obstruction, then they can have chronic raised ICP consequent upon hypercapnia. This happened in one of our patients. Other than that, we didn't see the raised ICP in any of our patients. So initially, in my first patient, we did the distraction when the child became about 12 years of age, and it was probably too much for him while he was waiting for the distraction. So from that time onwards, we have learned a lesson that it is better to distract them when everything is under control. And now we have realized that distraction can be done around the age of 5 to 6 years. And this red distractor, which has been made available to us by our hospital, is quite helpful now. And in most of these patients of Cruzen syndrome, as I have already said, that they are mentally quite okay. These combination of these surgeries can help them get integrated into society as useful members. Thank you very much.
Thank you, Dr. Ramesh Sharma, for a wonderful lecture. I think we'll take questions after 4 lectures because they're almost similar, and then we'll take questions from the audience. Okay. Next, I call upon Dr. Ajay Sharma. Sir, are you ready?
I'll just Dr. Sharma needs to.
I will stop sharing it. Yeah, I did it just
Thank
now.
you, sir. Okay, sorry about that. Actually, sorry, it took a sincere apologies. Actually, what had happened was the trust was trying to install OneDrive into my computer, and it totally screwed up my program. So once again, since a lot of thanks, and I appreciate the amount of work you guys put in from the Indian Pediatric Neurosurgery to organizes webinars. It's been a pleasure to join you, the old friends from India and from all over the world. And Dr. Sharma, you may not remember me. I was a junior resident in PGI Chandigarh when we were assistant professor. So
Oh, really?
doing some facial cases. So
it is such a
it's
small world.
We are much younger then, and I was nobody. So you would not remember me. We're talking of 1988.
I am still nobody, boss.
It's a small world.
Yeah.
So today I'm going to concentrate on our practice, especially because I work in the northwest of England, and it's the demographics of this place is very stable. There is not much of movement out of this out of our catchment area. So we have this unique opportunity to follow these patients up right from the time they were born, or even from before they are born, for a long time. So I'll just share some of my experience. I will not go in much into operative details because that is being covered by other speakers. Okay, so ignore me. So, as I said, my name is Edison. I'm a neurosurgeon by trade, and I work very closely with my plastic surgeon, maxillofacial, and colleagues. And ours is one of the 4 major units in the country who are designated supra-regional craniofacial units in England. And we cater to the whole of north of England pretty much, with a catchment area of more than 10 million population, which for Western figures is more than 10 to 15 million, I think. What 15 million, which will be quite a big number, not by Indian standards. And our team is quite elaborate. It's got pretty much everybody who needs to be there in a multidisciplinary craniofacial team. But the core members are the neurosurgeons and the respiratory physicians and the ENT surgeons who provide maximum support to the service, and others are mostly there to support the service, but they have a very important role to deal with it. Genetic syndromics, sometimes when we don't need a consultant geneticist to tell you that the patient has got a genetic diagnosis. This young man brought his daughter along, and the diagnoses were written up. When you see the dad, you know what we are dealing with. When you look at his hand, he's got a mitten hands, which he was trying to hide, and he's been living with it without treatment for greater part of his life. Only when he had a daughter did it come out that the dad was carrying the genes, and the family would take his appearance as normal. So the society expectations in certain parts of the world are quite variable, and this obviously will not be expected to be considered normal by any standards. I will not go through the whole list of craniofacial abnormalities. It's a very busy slide, but for all practical purpose, what we deal with is the 3 prominent ones who present early on for care: the Cruzans, the Afers, and the Pfeiffers. And the Sedgwick-Otsons and the Muenkis seldom require urgent treatment as newborn, and they only come much later on when they're slightly older to medical attention. So for all practical purpose, we're dealing with these 3 groups who require very early care, and in a large percentage of cases. Most of the conditions, as you know, are autosomal dominant, except for Carpenter's. Most of them are sporadic, and generally the diagnosis is made after birth. But nowadays, with better facilities and with better 3D ultrasound, we do come across a small percentage of cases which are diagnosed antenatally, and the antenatal clinic would call us for antenatal counseling and giving them appropriate advice as to what is expected when the child is born. And now that the unit has been existing as a supra-regional center for nearly 25 years, we do have a subset of children who have grown out to become adults, and they are getting into relationships, and they're planning to start families. So the genetic team need to get involved, because you have to give them all the advice. At the same time, also guide them if they're keen on avoiding this disorder into their children, for pre-implantation genetic testing and into in vitro fertilization for this condition. And we offer this service, but the uptake is very tiny. We're looking at 1 or 2 cases, maximum 1 to 2 cases per year. As we were saying about ultrasound becoming better and better, this is a case which I had to deal with only in the last 2 weeks. Young fellow who's been diagnosed with APERS in an ultrasound, 3D ultrasound scan, and you can see the mitten hands. the syndactyly is so prominent in this child. So I thought I'll share it with you. And this patient obviously is the mother is coming in for counseling in our clinic next week. So it's something which we have organized, and we are seeing more and more of it happening. Syndromic craniosynostosis is not an indication for medical termination of pregnancy in the UK. It's not a medical indication. Obviously, if the family wants to terminate before the viable age, that's absolutely fine. But it's not an indication for termination of pregnancy. Antenatal counseling is becoming more and more prominent, and with more and more widely availability of third trimester ultrasonography for growth-related issues, I think the uptake is going to get only more and more available in the more prominent in the near future, and the antenatal service will require somebody with craniofacial input to give them the appropriate advice. We do not recommend antenatal MRI routinely for these cases, but if possible, if the slightest doubt, we would always insist on the ultrasonographers to show us whether there is a cleft palate, because that has a lot of impact on feeding and early involvement of the cleft team. If we know there is a syndromic craniosynostosis, the first thing we do, because most of our patients would go to their local district general hospitals for their delivery, we'd always forewarn the ENT colleagues. In the past, we used to have a lot of children who get born, and before even we would be contacted, they would have a tracheostomy done. So the idea of forewarning them is try and avoid early tracheostomy, because that has a lot of bearing on growth and development, especially speech development. So we always forewarn them and try and tell them not to do a tracheostomy if possible. If there is slightest doubt, to transfer the patient to our center, when we will try and manage with our ENT colleagues who have a host of experience with dealing with these conditions. We do not recommend cesarean section, and in so many years, I have not seen a single syndromic child requiring an exit procedure. They go through their normal delivery and they do breathe very well after birth. The problem with breathing starts soon subsequently, but not at the time of birth. The idea is to avoid a tracheostomy and early detection of cleft lip. If you pick up cleft lip, then it needs to be treated and need to go down the route of early management, because that will have impact on feeding and weight gain, and subsequently will have impact on our practice. Why ENT? Well, most of them will have congenital nasal synostosis, with a septal deviation or narrow posterior nasal space, or or very narrow choana. That's something which we notice in a large percentage of these cases. And you see this particular scan, you can see that the choana is so narrow, and that may require this is a endoscopic appearance of the choanal spaces. They are so narrow that this child couldn't even pass a NG tube down to start feeding, and we had to go in for early choanal dilatation. And choanal dilatation may sound like a very difficult procedure, but for experienced ENT, it's a very common procedure which most ENT surgeons who deal with children should be able to do it. But also, apart from just dealing with breathing and airway, they have to look at the hearing, because that will have impact on speech and language development. And more than likely, some of the children who have severe posterior nasal space narrowing will also have conductive hearing loss. And probably there is a slightly higher incidence of sensitive neural hearing loss in the syndromic children. And apart from that, we all aware of the tracheal abnormalities in Pfeiffer's, the figure of 8 and the sleeve trachea, which is well described in Pfeiffer's and Apers. They can have various tracheal abnormalities which have to be factored in when we are going, because most of the children require as many as 50 to 150 in the broad range of general anesthesia before they grow into adults. As I said, what we have done is we use simple urethral dilators to do a serial choanal dilatation and keep the patients in. The ENT nurse specialist will try and teach them how to change their nasopharyngeal airway, which is inserted after choanal dilatation. And once the parents learn how to do the change themselves, and they're taught how to stitch the two flanges which are taped to the face, they're sent home. And of course, with regular monitoring and regular follow-up. And with this, we have been able to avoid tracheostomy in a large percentage of cases, especially in the last 5 to 10 years. Feeding is once again a major issue because some of the children, because they have got such severe nasal stenosis, nasal narrowing, they cannot breathe easily once they start feeding. So, in severe cases, you may need a orogastric tube because you cannot pass a nasogastric tube. And if you pass a nasogastric tube, then they can't breathe very well. So orogastric tube may have to be put in. We also do, in a large percentage of cases, if it's slightest of doubt, we'll do video fluoroscopy to rule out any aspirations. And if there is any suspicion of aspiration, feed thickeners, milk thickeners, when the feeding team will add various milk thickeners to avoid aspirations. And once again, the feeding team will also be very keen because when they also do the speech assessment, they'll be very keen to rule out conductive deafness and give the appropriate advice with regards to management of deafness so that the child's speech and language development subsequently doesn't get affected. The gastroenterology team are very early on involved because there would be a need for a PEG insertion or a percutaneous jejunostomy in some cases with severe reflux insertion early on. And what we do is link these cases to the local services who will monitor the feeding and give parent support in the community. And once again, the health visitors will be heavily involved in the management of them so that they can keep a track of the weight gain, because subsequently, if the child doesn't put on weight and doesn't grow, then surgery becomes a lot more challenging. The genetics team, nurse specialists see them on the ward, and if required, if the parents are keen, they will also get the genetic consultants to come in and talk. But generally, the nurse practitioners are very good. They give you all the necessary advice when the patients are admitted for inpatient support. And the craniofacial nurses are the link point who will be dealing with them on a regular basis and liaising with the health visitors in the community. There are a lot of online support available. Headlines is what we follow in the UK. It's a charity-run online support group, largely supported by the parents, and it's got a host of very good information, and anybody is welcome to access them. And there are some of the headlines, some of the written leaflets we'll provide to the team, to the parents, and these are the team, the nurses will bring them on. And if we've already confirmed a diagnosis of APERS or Cruzan, we also give them dedicated additional leaflets on APERS or Cruzans or Pfeiffer's. And this, along with this general information leaflet as to, it gives you a description of who the individual team members are and what their role is going to be in the management of these cases. The idea is to integrate them into the service and make them aware that it's going to be a journey rather than a one-off affair. And we might be seeing each other for a number of years, if not for decades. Yeah. So to coordinate all that, we always put this patient in the hospital for a few days. It's very difficult to coordinate all this care from an outpatient basis. So we bring the patient in for a few days as an inpatient, and during that time period, they'll have a CT scan done, they'll have a baseline craniospinal MRI. We do the head and spine as well as a matter of routine because of various spinal abnormalities you can find in bony abnormalities you can find with APERS. We always do a baseline TOSCA, which is a transcutaneous carbon saturation assessment. The eye and the ear ophthalmology team will come in and assess for eye closure, and most of the time they can manage with simple taping or various eye ointments and drops. And the neurosurgery team will come in, and because mostly the patients admitted on the neurosurgery ward, and that's a joint ward we run with the facial surgeons. So we will be admitting it in under our care to assess for any hydrocephalus, any need for any other treatment, which urgent treatment. But most of the time they don't develop raised pressure early on. And even if they have prominent ventricles, the trend is to avoid putting in a shunt, because if you put in a shunt, you increase venous hypertension, and that makes life 10 times more difficult subsequently. And what we do is put in regular follow-up, mostly led by the nurses at every 2 to 4 weekly interval, to see whether they're gaining weight and the parents are happy with the feeding and with the breathing. And we maintain a very close follow-up to start with. And as the child progresses, and the child and the parents who will determine the frequency of our follow-up and the duration of our follow-up. because what we don't want is a situation like this. This is one of our early patients. As you can see, this can be fairly challenging. And this was one of the few cases where we tried every possible conservative measure to protect his eyes, taping, tarsorrhaphy, and finally we had to do one of the earliest frontoorbital advancement. We did it at the age of about 2 months. These days, we would not go for a frontoorbital advancement. We do something else. And there could be, it's one of the few cases where there could be a role for early monoblock advancement. In our entire practice, we have done one monoblock under the age of 3. We tend not to do monoblocks on these cases. The other teams, especially the Great Ormond Street team, have been much more aggressive with monoblock advancements. We certainly do not subscribe to that because the complication rate for monoblocks in young children is exceptionally high. We are talking of 80 to 90% complication rate. It's a very high complication rate in our practice. So we would avoid them at any cost. So in terms of timing for intervention, the earlier you pick them, the better. If you can diagnose them antenatal, then you start preparing the parents with advice and counseling, which gets them into the scheme of things and allows them to access the services locally, regionally, as well as nationally. Once they're born, first thing to assess is the airways, the eyes, and the feeding. If everything is moving in the right direction, a small percentage will develop raised pressure, especially the ones who are the fifers and the multisutural ones. They may require a vault expansion with wide strip craniectomy. Not all of them require, but a small percentage will require. Our usual practice is to do a vault expansion used during this with distraction osteogenesis within 6 to 8 months of age group, and then frontoorbital advancement between 12 to 18 months. Once you've done a vault expansion with posterior vault distractors, this is a very flexible timeline. You can even do it at as late as 24 months. Between 2 years to 5 years, there's a lull period when nothing much needs to be done from our side. It's mostly the hand and toe surgery, the syndactylic correction, and other issues which need to be addressed. And the speech and language will follow them up very, very closely at regular intervals. And especially the 18 months assessment and the between 3 and 4 years assessment is vital, because that is the time children will start preschool. And as Dr. Sharma said, the leaf-forward osteotomy or facial bipartition or this or a monoblock, this is a variable timeline. We would generally determine that is largely determined by sleep studies, by the child's progress, and and the ENT concerns. And it's a variable timeline. We would try and push it as close to us 12 as possible, but sometimes our hands are forced, and we are doing it more nowadays between 6, 7 years of age, but we try and postpone it as we can. As children go through the growth spurt because of the occlusal malocclusion issues, they may require further surgery in the form of either a leaf-forward 1 osteotomy or mandibular surgery. And finally, if some of them would end up requiring finishing surgery in the form of forehead implants or a rhinoplasty, which would be done well into their late teenage years or into early adulthood. I also run the transition service, and some of the children do come for, finishing surgery much earlier, later on in their adulthood, in our adult craniofacial practice. But those are few and far between. So that's sort of a timeline we're looking at. The older they get, the less likely the neurosurgeons will get involved. So our involvement pretty much finishes by about 2 years of age, unless until the monoblock is planned. And most of the times, it's our involvement is in the initial 2 to 3 years. It's just a word of caution. I do see, because of my endoscopy skull base practice, I do see a tiny subset of patients who present much later on after leaf-forward 3 osteotomy with repeated with CSF leaks and meningitis. Just for somebody who's doing leaf-forward 3 osteotomy, be aware of this particular problem, and they may require endoscopic repair of a potential CSF leak from the skull base. We had at least 2 or 3 cases of them that time. So once again, just what we do is, in terms of initial procedures wise, once again, corneal dilatation, often we manage with NPA, avoid tracheostomy, feeding. The PEG is the commonest surgical procedure required at that age group. And tarsorrhaphy, very rarely beyond anything beyond tarsorrhaphy is required, but be aware of ocular dislocation, and may sometimes much more aggressive skull procedure may be required to prevent potential ocular translocations. And close follow-up with CT scans and MRI scans if there is any suspicion of raised intracranial pressure. Because the incidence of raised intracranial pressure goes up from being about 30% with bicoronals to almost as 100% with multisutural synostosis. So I'm a bit surprised in Dr. Sharma's presentation that he raised ICP figures as that low. Our experience has been much higher, and it's a very, very common determinant and of for need for further intervention. And the ophthalmologists sometimes may not be able to give us all the information because of the nature of their ocular problems. Even papilledema doesn't get picked up all the time. And just to give you a few examples, this young child was brought in at the age of about 1 month from another unit. This is going back nearly 10 years when our practice has changed since. He's come in with a tracheostomy in place. And this was a case of Pfeiffer's, we thought, multisutural synostosis. That's how he looked on the CT scan. We watched her very, very carefully. Within no time, she started getting crowded, turicocephalic, and getting crowded in the posterior fossa. And our initial plan was to do a vault expansion about 6 months of age. We're using distractors, but because of her breathing problems and frequent sleep apneas, our hands were forced. So what I ended up doing was doing a wide vault expansion, just removing multiple sutures and give space to the brain. And after a few months, the ventricle started going bigger. So I had to, a few weeks, I had to put in a shunt. And our usual practice is to put in a programmable valve for these cases. And I'll show you why. The next case, severe Pfeiffer's, this child, once again, as you can see, it's got big, wide open fontanelle, but there's very fuse at the back. And she had severe respiratory distress, had a suturectomy done, and then was stable for a good period of time. And then the ventricle, when the fontanelle started getting tenser and tenser, and with that, her saturation started coming down. And you could see that on saturation studies, she was struggling. So the only thing we could do at that point was to just stick in a shunt. And that is the time when I was away, and I'd left very clear instructions not to put in anything other than a programmable, because these patients can be quite challenging if you try and put in a box standard VP shunt. So this is the MRI scan prior to the shunt going in, and just watch out. A standard Methka valve is what we use. It's a gravitational valve. And somebody puts in the shunt, they can see that the fontanelle has just sunken in like that. It's become like a little, like a little bowl. It's like a boat-shaped sunken fontanelle. And what happened was, posterior fossa got completely crowded within a week, to the extent that this child went on to ventilator. And that was a bit of a surprise to us. We hadn't got a clue what to do because we never had this problem before. So the first thing I did was exteriorize the shunt. And guess what? Within no time, she improved. Her respiratory symptoms improved. And finally, we had to switch over to a programmable valve with an anti-siphon device. Nowadays, we'll put in a Prograph 2 anti-siphon, which has got a built-in gravitational unit. But programmable valve, please, is what we have been using, and this has been our experience. If you have to drain the CSF, use programmable valves. And she had a very tough time. So in terms of, I'll once again go over the timings because it's very important. Our strip cranectomy it's between 2 to 4 months of age, and vault expansion is through distractors is between 6 to 10 months, and frontoorbital advancement about 12 to 18 months. I'm not going to talk much about vault expansion through distractors because that's the topic of another talk today, and I'll leave it to the next set of speakers to cover that area. But we do it routinely in most of our Cruzens and Pfeiffers and Aperts, less in Aperts, but definitely in Cruzens and Pfeiffers would definitely go for early distraction to provide space. And it allows us to time our surgeries better, and perhaps the overall aesthetic outcome is much better with early vault expansion. So final thoughts. It's a multidisciplinary approach. There's the initial practice, maximum nursing support is what is required. And they require a lot of input, not from the surgeons, in the beginning, mostly from the health support services, other health professionals. In a small percentage, you may have to keep them in hospital, and they may require HDU support. But the numbers are few and far between. We had in the last 10 years, we had 2 patients who had prolonged stay in the HDU ITU setup, but most of them would settle down on, minimal oxygen support and can be managed in the ward and be sent home early on. And the trick is the communication. This is a very involved procedures with number of general anesthesias and several inpatients and outpatient appointments. You have to keep the family well engaged. They will pretty be on first name terms by the time you finish with them. They would know you, you would know their other children, and they would usually bring in the other children to make sure that the other fellow doesn't have a craniosynostosis, just for reassurance sake. So when you see the children coming in, you see the actual patient, and also you see 2 of the siblings in the clinic, just for reassurance. And our main theme early on is to avoid a tracheostomy at any cost. And I'll stop there. Thank you so much.
Thank you, Dr. Ajay Sinha, for a wonderful, wonderful lecture. I will take the questions after 2 more talks. So next,
thank you so much.
Thank you so much. Next, I call upon Dr. Ricardo Santos Oliveira. He is an associate professor of in the Division of Pediatric Neurosurgery, Sao Paulo, Brazil. And he's also the current president of Brazilian Society for Pediatric Neurosurgery. Ricardo is very famous in his country for having successfully separated craniopagus conjoint twins. Ricardo, over to you. He will speak on mid-phase distraction osteogenesis for syndromic craniosynostosis, indications, results, and follow-up. Ricardo.
Thank you, Deepak. Thank you, Deepak, for this kind invitation. It's kind words for you. So, say I will share my screen now. I'd like to thank you for this kind invitation. It's a great pleasure for
Deepak, I think
you're not audible.
Yeah, sound is not coming.
Ricardo, you're not audible. Your slides are running. Make it full screen, please. I think he has recorded a video. Ricardo,
yes, Deepak. Yes.
You're not audible at all.
Yeah, you can see my screen?
We can see your screen, but we cannot hear anything.
Sorry, I try to share again. Sorry. You can hear me?
I can hear you. We can hear you very well now. But I think what you are showing, it's a pre-recorded talk, is it?
Yes. I recorded because the time. I try to share. If it doesn't work, I have the presentation now.
Yeah, just make a presentation, and we don't worry about the time. We'll adjust. Okay.
Okay.
That will be much better.
Okay. I will share my presentation. No problem. Okay, it's okay.
Perfect. Yeah, go on.
Perfect. Okay, no problem. So I'd like to thank you so much for this kind of invitation. And my topic is about mid-phase distraction osteogenesis for syndromic craniosynostosis. So I would like to talk something about indications, our results, and follow up with our series. So I divided my presentation in these main topics. So some words about the introduction, indications, the redivides that we usually do in our series, and follow up, and some clinical case illustration. So the four main topics that I would like to share you now is about surgery for facial craniosynostosis involves a complex technique that we just see now the two previous presentation, and it's very, very common. The aim is to prevent the cerebral damage, correction of facial retrusion, the exorbitism, and upper airways impairment. Posterior expansion and frontal facial advancement are good options and should be tailored each by case. And one or two-step surgery is still on debate on literature. So about indications, it's very common. The multiple synostosis involving in syndromic craniosynostosis, the raised intracranial pressure, exorbitism, maxillary retrusion, and also sleep obstructive apnea. So summarizing, the main features is raised intracranial pressure, exorbitism, maxillary retrusion, and obstructive sleep apnea. So I review a timeline about distraction osteogenesis, and it's very interesting. In the last century, Professor Harv Cushing published some papers using multiple small craniotomies to treat syndromic craniosynostosis. And then some years later, in Boston, Ingram and Madsen published their books about neurosurgery of infants and childhood, and they showed low mortality in this kind of problem. And Dr. Elizarov was considered a pioneer of distraction osteogenesis using external device to treat fractures. And Paul Tessier is the craniofacial surgery and published many papers using osteotomies to treat syndromic and non-syndromic patients. And finally, in the 7 decades, the Karen Formalades published their series using a standard and defining standard techniques to treat craniosynostosis surgery, as Dominique Renier and Daniel Marchal. And finally, in 78, Ortiz Monastery published their series using a frontal facial monoblock to treat syndromic patients. The problem of this technique is the high complications involving. In 1992, Joseph McCarthy introduced the concept of gradual distraction initially to treat, to lengthen the human mandible. And in the 90s decades, we defined it on the CARES team, the craniofacial advancement and the Lefort-3 mid-phase surgery in 1 or 2 steps. And in the last decades, published the largest series involving a ridge distraction to treat syndromic craniosynostosis. So the aim of the surgery is to recognize the need of a staged reconstructive approach serves to clarify the objectives of each phase of treatment for the surgeon and the family. Multiple surgeries may be required for each deformity in different time, and the multidisciplinary team is the goal to reach good results. So the main step when we're talking about the frontal facial advancement is to understand with the team to make the forehand and the frontal orbital advancement and also the mid face, and using the rigid device to stabilize the frontal facial advancement. So it's very important. One critical step in this surgery is the bilateral pterygomaxillary disjunction and as well the division of the midline structures is performed systematically along operative mobilizing of the complete frontofacial assembly. After the monoblock surgery, usually we use external or internal device according to the age of the child. In this case, we're using the internal device when we have a child under 4 years old and a good collaboration. We use internal device or external device over 5 years old. And also we can using absorbable screws to fix the internal device on the skull of the young child. This is a CT, a 3D CT scan showing the vectors that we can reach using the internal or external device. So this is my personal series doing surgery in non-syndromic and syndromic craniosynostosis. In the last 21 years, we treated 42 patients with syndromic craniosynostosis. From this, 33 patients submitted for craniofacial distraction surgery using internal or external device from 2003 to 2020. The average lattice period before activation of the re-distraction was 5 days, and activation period ranged from 7 to 15 days, and the consolidation period was 8 to 12 weeks. So 27 cases using monoblock frontofacial and 6 LIF-4-3 mid-face advancement surgery. So mid-face was distracted on average of 16 millimeters with a range to 12 to 22 millimeters. Short and long-term CT data demonstrated good ossification of the ostomy sites post-distraction, and all patients presented with good correction in terms of exorbities, respiratory embarrassment, and stabilizing intracranial pressure. Unfortunately, our worst complication was the CSF leak that was the most frequent in our series in 15%. This is our institution. We published our series on the literature. And now I will present our protocol for craniofacial distraction. So osteotomy is frontofacial monoblock in 1 step or LIF-4-3 mid-face advance in 2 steps. Postoperative in pediatric unit care. Usually, now we diminish our time to 24 hours ICU in pediatric ICU. Activation of read system at 5 days, and maintenance of the distraction in place for at least 4 and 6 months. Some clinical case, Cruzone syndrome, born in 1990. The treatment was previous in 2000 at 1 year of age, a classical frontal orbital advancement, and then in 2003, it was our first case operated with Professor Henrique Arnaud from the care using an internal device in our institution. This is he looks like in 2004 before the osteogenesis distraction at 1 year of age. So during the distraction, after surgery, and the pre and postoperative after removal of the internal device. Another interesting case, a guy that lived in the North region, Brazil, 9 years old. He hadn't never been operated before, and he was transferred. He was referred to our institution during 2009, and we did the frontal facial monoblock advancement using an internal device. This is looks like the CT raised intracranial pressure, and unfortunately, he lost one vision, the right vision, because of the chronic exorbities, and he was treated in his origin hospital. And when he was referred to us, he hadn't anymore this vision in the right eye. This is the severe exorbitism and also a mid-face retrusion. We're using at that time the model prototype. We draw the osteotomy lines before the surgeon is studying all the steps before surgery. Some pictures took during the surgery. You can see here the signs of intracranial pressure and how we install the bilateral internal device. So it's very common. This kind of syndromic patients had a fragile zygomatic, frontal zygomatic junction. And so it's very common to reinforce with some mini plates and screws to stabilize the frontal orbital bar. So how is the guy after the internal device distraction? And 15 months after removing the internal device, a good result. As you can see here on this slide, the pre, post-operative, and after the removal of the device. And the CT, pre and post-operative. A Pfeiffer syndrome treated also with a previous frontal-orbital advance at 1 year of age. And then at 11 years of old, we decided for a LIFR3 advance using an external device. This is the preoperative, a severe maxillary retrusion and also nexorbitism. And after 20 days after external distraction, and 5 months postoperative at the moment that we removed the external device, a good result. So pre and postoperative. This is an acanthosis nigrans, is a specific mutation that you can see in some Cruzon syndrome. This guy had a tracheostomy, previous tracheostomy, and the treatment was a frontal facial advancement with internal device. The preoperative, some typical signs of acanthosis nigrans, the pictures showing reinforcement, the frontal zygomatic suture, internal device, and pre and postoperative at the moment that we removed the internal device, and also we reached to close completely the tracheostomy after the distraction. This is the youngest patient that we treated with internal device. It was a Eppert syndrome. We decided to treat with internal device at 7 months, but we agree that it's the risk to have complications high. But in this case, the team discussed to treat it at this moment with distraction. So the preoperative and 6 months after removal the internal device. These are some emergent situations. As you can see here, a bilateral luxation of the orbit, a tracheostomy in a Clover-Leaf Pfeiffer type 2. And this is a very dramatic situation. And you need to try to save the orbit doing with the oculoplastic and to save the vision of this child. So it's a dramatic situation that you can see in some specific case. A teenager, 14 years old, never been operated before. And in this case, there is no severe exorbitism. We decide for a LIFR3 surgery using external device. As you can see here, the postoperative result, pre and postoperative. The CT, and this is the virtual planning as that you can measure the advancement that you can reach in this kind of patient. This is a very interesting case, again, at pre-teenager, 12 years old, a Cruzon syndrome, never been operated before also, and a severe exorbitism and also a mid-face retrusion. The CT showing a very high intracranial pressure. We studied now using a virtual planning, so we can draw all the osteotomies studying with our team. And this is how it looks like after distraction on the computer. And we customized for this girl external device for the first time in our institution. So during the distraction and after the advancement that we reached in this girl, and the postoperative result was quite good. This looks like the distractor that we use in that girl. It was customized and low cost in our institution. Unfortunately, of course, we have many complications, and as you can see here on literature, the Necker series is the largest series published. They show it almost 27% of complications. So the most common are cerebrospinal fluid leaks, hypovolemic shock because of bleeding, multiple osteotomies, necessity of revision surgery because of dysfunction of distractor, local infection, fractures. High cost of materials is a big problem in low economic country, and multidisciplinary team is not easy to reach and to construct, to build multidisciplinary teams to take time, as it's very difficult to establish a routine work at the beginning. Just one case in our series that I would like to present to you. It's a Pfeiffer syndrome. We decide with severe exorbitism and mid-phase retrusion. We decide for internal device for craniofacial destruction, but unfortunately, during the distraction, there was a blockage and incomplete distraction. We propose a revision of the surgery. However, the mother refused the revision, and we removed the internal device, but unfortunately, we can see early a relapse of the mid-phase retrusion. So in conclusion, distraction has become a safe method for the correction of deformities of the craniofacial skeleton in children with syndromic craniosynostosis. It also involves a learning curve, and a multidisciplinary team is mandatory. And distraction osteogenesis allows early correction of a respiratory impairment and exorbited in facial craniosynostosis. A stage reconstructive approach allows our dissociation of problems and minimize risks. Frustration and discouragement could happen in a team, but keep walking. Thank you so much to present.
Thank you, Ricardo, for a wonderful talk. I really enjoyed it. I'm sure everybody here would have enjoyed your talk. We'll have one more talk, and after that, we'll take up the questions. Next, I call upon Dr. Desi Rodriguez. And Desi is popularly known as Desi, and Desi actually means Indian in our language. So he's truly an Indian. So his full name is Dr. Desi Didario Rodriguez. He completed his medical graduation and post-graduation from Goa Medical College. I'm sure all of you know where Goa is situated like. He did his neurosurgical training in the United Kingdom, and now he's working as a consultant pediatric and craniofacial neurosurgeon at Birmingham Children's Hospital, which is one of the 4 designated supra-regional centers for craniofacial surgery in the United Kingdom. Desi, without wasting any further time, I call you to share your talk and to share your views about management of common syndromic craniosynostosis, including emergency interventions. Over to you.
Yeah. Thank you, Deepak. Thank you for inviting me and for the kind introduction. I will say that most of the other 3 speakers have talked most of in detail the management of the various syndromes and what they do. So I won't hold any apologies if I repeat the things. Now, for any craniosynostosis to be called syndromic, there should be these 3 features. There should be a premature closure of either one or more cranial sutures, at least another congenital abnormality either in the limbs, face, or the viscera, and a gene mutation or deletion should be present. We know that the incidence of syndromic craniosynostosis is much less than non-syndromics and varies anywhere between 1 in 10,000 live births to almost 1 in 160,000 live births. Though there may be phenotypical variations among these syndromes, most of them at some point will present to you with multi-suture synostosis. And this causes the craniocerebral disproportion needing neurosurgical intervention. The incidence of raised intracranial pressure, as Ajay has kindly said before, is more than 40% in syndromic craniosynostosis and can be as high as 83%. Even following the first cranial surgery, these children can develop with recurrence of raised intracranial pressure. Also, the cause of the raised intracranial pressure, as Professor Sharma has said, can be multifactorial. Even just building up carbon dioxide because of their respiratory problems can give rise to raised intracranial pressure, which we see quite often. So it is very important that each of the causes identified and treated on its own merit and not just rushed in to do a calvarial expansion if there is raised intracranial pressure. You have to make sure that this patient is not having obstructive sleep apneas and building carbon dioxide. That will need addressing first. So to say, management of these cases can be broadly divided into three main headings. Emergency interventions, which are for airways and for the eyes, as we have already heard. Then urgent interventions for raised intracranial pressure and to facilitate optimum brain growth. And then the elective interventions for aesthetic issues, for the limbs, for speech, and for dentitions, which can come on later. Hence, managing any syndromic patient needs a multidisciplinary team. As you can see here, what all it involves, and Ajay has already told you all what Alderhay does, and this is all what we have at Birmingham Children's Hospital. We are only part of the spokes in the whole wheel. So what is the role of you as a neurosurgeon within the team? Is it only operating, as many of you may think? No, my friends. You as a neurosurgeon have a very crucial role to play in the decision-making process. You have to decide who needs operation, when to operate, and what surgery to offer. You need to avoid pitfalls during the surgery because these children have got varied anatomy. Their venous structures are different. Their bones are different than just any other patient you would operate in neurosurgery. And also during the surgery, you could run into problems, and these problems can be life-threatening. You are crossing the sinuses, you are crossing the torcula. So remember that if you have to deal with this, nobody else will come to your aid, and you have to sort these problems out. If surgery is to be offered for raised intracranial pressure, you as a neurosurgeon have to decide, based not only on aesthetic consideration, but also how much volume does the patient need. We've just heard that we in the UK prefer posterior calvarial surgery to anterior calvarial surgery because we know that it has well been documented that posterior expansion gives you almost 30% more volume than anterior surgery. So what we do at Birmingham Children's Hospital, for most of our syndromics, even for bicoronal synostosis, we will prefer doing a posterior expansion by using distractors as a primary procedure, and we reserve the anterior surgery for aesthetic reasons, or should they need further frontofacial advancement, then it's nice to have a virgin territory for you to work on. So all our syndromic cases are assessed in a multidisciplinary setting as seen here from time to time, right from the time of referral up to the adult life. So you can see they are initially for up to 2 years seen 6 monthly intervals. But remember that between 0 to 2 years, our nurse specialist also keeps a telephone check and brings them often to his own clinic to see them. Then thereafter, after 2 years to 16 years of life, all syndromics are seen on a yearly basis with ophthalmology input to pick up any early signs or symptoms of raised intracranial pressure. At the age of 16, they are transitioned into the adult world, where the same team sees them in the adult world. And at 18, we discharge them with an open appointment to contact us anytime should they need any help from us. So at each review, we at Children's Hospital will assess these children both clinically for aesthetic and for any raised intracranial pressure symptoms or signs. The ophthalmology too sees them, And if there is any concern, we will then go on to doing imaging on them. And if all this confirms that there is raised intracranial pressure, they go on to have surgery. However, I should say, like in Crouzons, we see a lot of children coming with Chiari malformations. So if they're symptomatic, we would say that we would offer them surgery, but otherwise sometimes we wait and watch. Should there be suspicion of raised intracranial pressure, but radiology and eye is equivocal, then we consider intracranial pressure monitoring with them with O2 saturation monitoring overnight, and we do this for 48 hours. It would be ideal to have sleep studies performed at the same time if possible. If this proves that there is raised intracranial pressure, then they go on to have surgical intervention. If not, they are closely followed up again at anywhere between 3 to 6 month intervals. So now coming to individual syndromes, you've already heard that APERS children have a lot of other problems, airway problems and breathing problems. So what we do is we follow them expectantly in a multidisciplinary setting. For their airways, they are seen by the ENT and the respiratory team. We look at them from the intracranial pressure point of view, both the neurosurgeon and the ophthalmology, and we are joined also by the plastic surgeons for their hands and feet, as well as looking at their midface. They are also the speech and language therapy team will assess them regularly for their feeding and for their speech problems. All these APERS children, besides having mid-face hypoplasia, they also have other structural airway problems such as reduced pharyngeal volume as well as laryngotracheal abnormalities. And these need addressing. So these are addressed. The airway is addressed with various maneuvers. First of all, as Ajay has already said, we will prefer using, when they're very young, nasal stents or using choanal dilators. You dilate the choana and then you put nasal stents and you can tide away the problem. Some of them will go on to needing tonsillectomies and adenoidectomies. We also tried the nocturnal CPAP, which personally in Birmingham Children's we prefer avoiding because using CPAP can cause more pressure over the midface, facilitating further regression of the midface. Tracheostomies are kept in reserve for those who cannot be managed otherwise. Of course, midfacial advancement, as we have said, is done later on in life, except in very, very occasional circumstances where you may have to use a transfacial pin even in the neonatal period. Here is just to show you all how it looks. Now, when it comes to raised intracranial pressure, this can be due to hydrocephalus, in which case one would want to consider CSF diversion procedure. I would like to say here that although most of the children will have big ventricles, only 10% of them will have actual hydrocephalus. So be careful when you just look at big ventricles and decide to put a shunt. It can be counterproductive. Most of them will develop raised intracranial pressure due to craniosynostosis. Here is a typical example of a child who we were following up closely and who at 1 year of age developed raised intracranial pressure. So he has got bicoronal synostosis. So normally you would argue that it's better to do a fronto-orbital advancement for this patient since he's 1 year old. However, we decided to do a posterior calvareal expansion surgery using distractors. And this is what we get. We achieved a distraction of 2.5 centimeters on him over a 3-week period. And this is he at the age of 3. We operated him at the age of 1. 2 years follow-up later, he looks aesthetically as well as functionally is doing very well. With regards to Crouzon syndrome, they have a variable spectrum from mild, where sutures may be present at birth but close later on in life, to severe, where they may present with cloverleaf deformity. These children, as Dr. Sharma has already said, have midface hypoplasia and very shallow anterior cranial fossa flow as well as shallow orbits. And this causes them ocular proptosis and even globes luxation. So all these children require close monitoring, just like in APERS, with a multidisciplinary input for their airway, eyes, as well as for their ICPs. These patients develop multi-suture synostosis over time, and we will see that many of them will present with Chiari malformations and also syrinx. They also have skull-base abnormalities, which causes venous hypertension, which then further promotes Chiari formation and syrinx formation. With regards to the eye problems, they can develop exposure keratitis because of their proptosis, or as we have seen, ocular subluxation. And this needs addressing. And the way we address them is with simple measures like topical protection using artificial tears or ointments, or even considering temporary tarsorrhaphies till they develop a skeletal maturity where we can consider fronto-orbital advancement or even frontofacial advancement, that is a monoblock surgery. I would like to describe this case because, as I said to you, many of our patients will have craniosynostosis for causing raised pressure, and they develop Chiari and a syrinx. Here is a scan of a 6-year-old child who presented to us with headache, papilledema, and gait problems. Her CT scan had shown pansynostosis. As you see here, she also has got a Chiari malformation. You can see a syrinx within the spine, and you can see a sinus pericranii because of venous hypertension. Normally, a neurosurgeon, if he had to see this patient with a Chiari and a syrinx, would offer her a foramen magnum or a craniovertebral decompression. But in these children, you have to be cautious because this can be, again, problematic. If you decompress the craniovertebral decompression, the pressure from the supratentorial area will push everything down south, and you will end up into problems. So we decided to do on her a posterior calvarial distraction. And as you can see here, we did a supratorcular cuts because she had huge veins coming out. We always prefer doing a venous study before we subject these patients to a posterior calvarial distraction, looking at the sinuses and the torcula to decide how we can go and how safely we can go across these. Following the surgery, you can see now her Chiari, which was below C1, has gone to almost above C1. This is within a year. And in the next picture, you will see that her extensive syrinx, which was there, is hardly noticeable here. And this is her 6 years down the line at 12 years of age, doing very well. When it comes to management of Pfeiffer's, I find it the most difficult condition to manage. Type 1 Pfeiffer's are mild and have better prognosis, whereas the other two subtypes are difficult and have a poorer prognosis. These children are again monitored closely for their airway, eyes, as well as for their intracranial pressures. They will need calvarial surgery at some point, and their surgery is difficult as they have a lot of lacunae within their skull. Their skulls are so thin, and you can see small holes through which brain actually protrudes out. So you have to, even when taking their scalp down or the pericranium down, you have to be careful that you don't tear the dura or injure the underlying cortex. These patients also have venous hypertension, and this causes a lot of bleeding. So you have to control the bleeding right from the time go when you're taking the scalp down. Type 2 and 3 are quite difficult to treat and will need very early interventions, not only for their airways and their eyes, but also for their skulls. They develop severe cloverleaf-like deformity and a lot of lacunae within their bone. You can see here, I have sort of tried to take each peel. I'm marking the edges where there are bone islands, and you can see here the brain protruding out. So you go peel off little chips of bone and keep them aside. And what you do is you do some amount of calvariectomy because they'll regrow the bone. So you give them time so that their pressures are not raised, so that they develop more bone by the time they grow in age, and later on you can consider a calvarial expansion surgery. Most of the Pfeiffer syndrome patients will develop hydrocephalus and will need CSF diversion procedure. So, to summarize, my friends, the primary aim in management of syndromic craniosynostosis is considering an appropriate intervention made before airway, eyes, or the brain at the appropriate time. Remember, they will need to be followed up right from the time of referral into their adult life and beyond. So to take home, this would be my message to you all. When managing syndromic craniosynostosis, it is not all about operating, but having a holistic approach. Time your intervention carefully and as per the clinical need. Bear in mind that all these children have a natural inclination towards a relapse depending on what type of syndrome they have, and they will need multiple interventions. I would like to acknowledge my craniofacial team and my craniofacial colleagues, including Girish Solanki, who will be talking later on. And I thank you all for listening.
Thank you. Thank you, Desi, for the wonderful talk. Now I hand over to my panelists for today, Dr. Dilip Panikar and Dr. Dwarkana, to take it from here and to ask maybe the faculty any questions and also take up the questions raised by the audience. Dr. Dilip and Dwarkana.
Thank you, Deepak. And I must say that it was an absolutely wonderful session. This is something with craniosynostosis. The more you listen to it, the more you learn. You always pick up something a little bit new here and there, and that helps to improve the outcomes on your next patient. I think a few points that all the speakers raised repeatedly is the fact that as opposed to non-syndromic craniosynostosis, syndromic synostosis is an entirely different disease which requires multidisciplinary support. These kids have multiple issues and they need support in all possible ways, some expected, some unexpected in many ways. And the team must be very flexible in deciding what the child needs and how to sequence procedures depending on the needs of the individual child. So I have a question for the speakers, maybe Ajay, Dr. Rodriguez. You spoke about about intracranial pressure, and how often do you end up monitoring intracranial pressure when clinically it's equivocal?
Can I take this question? I mean, it depends on the unit's practice. I mean, I know like we have 4 units in the UK. I mean, Oxford, say for example, they have a very, very low threshold to monitor pressure. They'll practically do it for 100% of the cases. Now, for me, syndromic, most of the times, it's Pandor. You don't have to do a ICP to confirm or rule out intracranial pressure because there'll be other associated features which will give you a very good clue. You'll have, look at the bone, they'll be so copper beaten, they'll have holes everywhere. If you look at the scans, you get a fairly good idea about whether the pressure is raised or not so raised. I mean, it's a combination. When in doubt, obviously, ICP monitor. We tend to go by regular eye monitoring, regular eye examination, MRIs, CTs, plus in older children, when they're gone past the surgical procedures, any doubt of drop in school performance or any behavioral change, especially night cries, that's something which we find in a lot of children. Parents will tell you that about 2 o'clock in the night, suddenly the child becomes very, very upset, wakes up, takes a couple of hours or an hour to go back to sleep again. That's a very strong sign of raised ICP. So the actual need in our practice, I think less than 10%. We would not do regular ICP monitoring, but eye examination, close check on their respiratory functions, they have regular sleep studies, regular speech and language assessment, psychological assessment, and school performances is what we'll fall back on most of the time. you quite rightly said, you need to monitor ICP all the time. We had a few cases who have presented fairly late, and you wonder whether you need to do any vault expansion on them, or can you go straight for a frontal orbital advancement or a monoblock. In some cases, we have had to put in an ICP probe, and surprise, surprise, or they will come with an ICP reading from another non-craniofacial neurosurgical unit, and the pressures will be about 30, 35, and the unit will panic and transfer the patient across. So what we have done in 2 or 3 of those cases, we have started using what is called a romantic implantable device. This is like a ceramic disc, about 50 pence in size, which is inserted in the frontal area, and that allows you to monitor the pressure post-distraction. Now, we've done it for a few cases. It's not something which is inexpensive, and it's not something we would do for all the cases. But in some cases where the pressures are very high, we were not too sure whether just doing a posterior expansion will take care of the ICP, or whether we need to add something more to it. And surprise, surprise, what we found that even in the pressures over 35, you do a centimeter of expansion or half a centimeter expansion on the table. By the time they're day 3, day 4, with early expansion, because in those cases you don't want to wait, you find that the pressure drops exponentially. It'll be 35, it'll be down to normal within 3-4 days, and below 10 within a week or so. So, ICP monitoring is required, but it's not a must, and you should use it very selectively.
Yeah, I agree. Can I just say, I agree with Ajay. I've kept a complete data of other ICPs that we have monitored at Birmingham Children's Hospital from 2008 till today. And I should say, I've looked at the data before this talk, and I have only ICP monitored less than 5% of our patients.
I couldn't agree more. Yep. Very, very rarely.
I have another question now, a technical query for all the speakers. One of the issues that you occasionally face with with syndromic craniosynostosis are very, very large emissary veins that come up. I think Dr. Rodriguez, you referred to a patient where you had a clutch of emissary veins around the torcula, and you had to limit your the craniotomy for the posterior distraction to supratorcular. But what happens when you have patients who have venous obstruction and multiple emissary veins? How do you work around that?
Now, for our patients, I usually, especially if I'm considering a posterior distraction, I always get a CT venogram. Look at their venous drainage. Look if they've got the sinuses draining adequately. Look at the jugular vein if it's stenosed or no. And if that's patent, I am ready to sacrifice the transcranial veins which are coming out, the emissary veins. I know that one of our sister hospitals had a problem where the patient stroked out when they took the main draining vein. So from that time, I think all our units are very cautious, and we all look at the venous drainage quite either by MR and venogram, but I prefer a CT venogram, that gives you a better information. Now, if there was a draining obstruction to the draining vein and the emissary veins are going to be in here, then you have to consider how best you can do a calvarial release. We might not go for expansion, then we may have to consider something in the front. Instead of going for a posterior expansion, you might have to consider a fronto-orbital advancement or just lateral release and lateral expansion through limited incisions.
Yep, agree. I mean, in one case, when we had such prominent emissary veins, and you quite rightly said, they were the main emissary veins draining out the superior posterior sagittal sinus. We converted that case to an anterior vault expansion with distractors because the child was barely 6 months old. So we have had to change our practice depending on the emissary veins. But those are few and far between. I suspect, Dilip, you might be getting a slightly older age group patients who not had any intervention. So they are more likely to be very challenging in your practice than what we see perhaps here.
Okay, thanks. It's nice meeting Dr. Ajay, Dr. Desi, again, Dr. Ricardo. Hi.
Hi, doctor.
Yeah, nice seeing all of you again. And I had two questions. One is a very simple question as what are your criteria for discussing, for deciding for posterior distraction versus FOAR in early patients? Do you go by the shape of the head, or are there any other factors in which you say that, okay, posterior distraction is enough, or is it the age of the patient, anticipated blood loss? What are the criteria you select while selecting posterior distraction versus FOAR? And the second one is a slightly controversial question. I was reviewing some papers, and one was on the intellectual ability cognition improving after craniosynostosis surgery. I mean, what are your comments on that?
Okay. I mean, Desi will add to it because his units have a much longer experience of doing distractors than we have. For me, doing for posterior distraction is presenting early on, about six months of age, preferably between 4 to 6 months of age, increasing ptudicephaly, crowding posterior fossa, large occipital overhang the posterior fossa, small posterior fossa, and if there is an added syrinx developing, then that's a very strong indication for doing it. And it's general evidence of raised pressure on the scan. If there is any, if you do an MRI scan, you find that the optic sheath is dilated, that's an added extra layer of evidence to add to it. But increasing ptudicephaly and very crowded posterior fossa with or without a Chiari and a syrinx would be with a strong indication for me. Jesse, do you want to add anything else?
No, I agree with you, Ajay, but in Birmingham Children's Hospital, for most of the syndromics, unless their front is really bad, we prefer the posterior surgery and we keep the anterior surgery reserved for a later date if required. Because as you have seen in the slide I showed you on APETS, we did a posterior distraction for bicoronal synostosis and the front improved over time.
Yep. Yeah, agree. And in fact, we wrote a paper ages ago. I mean, this was published in Journal of Craniofacial Surgery in 2008 or 9, because the current craniofacial fellow here, she came as an observer, and when she did the study with me, so it goes back more than a decade now. And what we found that in our traditional practice of doing a frontal-orbital advancement alone, without posterior distraction in syndromic cases, quite a large percentage of these children will present with orbital pseudomeningoceles. The globe will start getting pushed down and they will have big pseudomeningoceles developing, even when there was no dural tear, because as if there was a growing fractured skull and the whole dura was trying to find a way in. And the best site was, because we used to be very aggressive in our frontal orbital advancement, the brain will try and herniate through the orbital roof defect. And I think we had about 7 or 8 cases which we wrote it up, and all of them would require going back again, trying to repair the roof of the orbit and trying to sort out the problem. And the eye movements will never return back to 100%. Once we started doing posterior distractions, I don't think we had a single pseudomeningocele. Goes to show that it was the raised pressure which were driving them, rather than and if you do something in the presence of raised pressure, the chances of CSF leak complications like pseudomeningocele are much higher.
Yeah. And also remember that blood loss is more in fronto-orbitals than in posterior distractions. We don't use any blood transfusion in posterior distractions, and the operation itself takes you an hour and a half.
Yeah, it's a one-session case. By the time they get the patient into, it doesn't take more than half a day to do a posterior distraction. Yeah.
Correct.
And coming for the second part, the intellectual cognitive comments, Dr. Ricardo, Dr. Ramesh, Dr. Ajay, Dr. JC.
I'll let others do the talking. I've done all the talking.
In fact, even Dr. Mahapatra asked this question to Dr. Ramesh, regarding this mental status, how long the children should be followed, should it be up to 16 years or, lesser period? So Professor Mahapatra has sent this question to me for you, Dr. Ramesh.
Yeah, see, most of the patients which I have followed, they have completed their schools now, and I make it a point to tell the parents to bring their school progress chart, and I find that they are doing reasonably well. I'm talking of Cruzan's patients. I can't say the same about patients with Epert's or Pfeiffer, but the Cruzan patients in general, I find them they are mentally quite normal, so to say.
Agreed. Yeah. I think that's been our practice as well. The cruisers and a small subset of APERs as well. They've done, and quite a few of them are holding jobs, and they come later on with some minor, concerns. But yes, you're quite right. The cruisers tend to have, but even in cruisers, the incidence is about 50%. 50% still have significant cognitive deficits. It's not something which we can ignore it. Even in cruisers, most of our syndromic patients, even the so-called in mainstream school, they're not the high flyers. They're mostly towards the back end of the class.
That is correct. That is correct.
We have one or two patients who have done very well and who are intellectually, very well, doing very, very well indeed. In fact, they are high flyers. There's one who is a maths wizard. He's a croissants, but those are few and far between.
Dr. Suresh, you had
a wonderful presentation by all the speakers, and as Dilip said so rightly, more you hear about this craniosynostosis problem, more curiosity it generates. So I won't go into the much details of all these things. Just a brief questions to all the speakers. How do you manage the hydrocephalus? I have seen Ajay showing one case where he put a shunt. So Ajay, let us start with you, and then Ricardo, please tell us how to manage the hydrocephalus, and if you put when it is versus shunting and ETV, and if you put the shunt, when you remove the shunt after expansion procedure. Can you please let us know?
So as I said, we are trying with posterior vault expansions, Suresh, we are seeing less and less need for shunts. Definitely the indication for shunts has come down. But if I have to do a shunt, I have still under one, I've still been very reluctant to do third ventriculostomy of them. I can, off the top of my head, recall only 2 or 3 cases where I have tried ETV. There's one particular case where we did a posterior distraction and it started leaking CSF post-op. So when you looked at the size of the ventricles, were very big. So what I did was slightly out of the box. I went in, did a third ventriculostomy and did a lumbar puncture at the same time. And that itself sorted out the CSF leak. So we have a few like that where, we have got away with ETVs, but generally a small percentage, the ventricles will continue to grow bigger despite vault expansion, despite suturectomies. And in those cases, the trick is not to put in anything low drainage system. Try to put in a high, high tension system, high resistance system, whether you put in Orvis Sigma valve, or what we tend to use nowadays is the Methka valve with programmable device, something with an anti-siphon, something with a high resistance, because the venous hypertension is a problem with them, especially in the early part of vault expansion when we haven't been able to, sort it out the venous drainage that well, because the venous system takes time to mature. The venous drainage through them is through the facial veins in the beginning. The jugular system only takes over to after 6-7 months of age. So the jugular system is not mature by the time you've been doing a vault expansion, and you may get into trouble early on if you put in a shunt before 6 months of age. So avoid over drainage. That's the key.
Okay, Ricardo.
Yes. Thank you, Suresh. Thank you for your comment. Yes. First of all, when you consider this kind of patients, syndromic patients with hydrocephalus, is a very problematic patient, because in one part you need to treat the hydrocephalus, and in another part you need to think about what you will do in terms of osteotomy and cranial expansion. So it's a contradictory. If you put a shunt, you can limit the expansion of the brain, and it could be very complicated in terms of multiple surgeries and brain expansion. I will try, or I'm trying in those cases, first studying the anatomy, try to ETV, because maybe it's more physiologically. But I agree that in some cases it doesn't work very well. But in most of cases, you can postpone the shunt indication, and then you start by a ETV, And then in some cases, you don't have another chance, you put a shunt, of course. It's, you can do other thing. Posterior expansion, for me, it's a very useful procedure. But, you know, when you see a patient with a severe exorbitism or even a severe respiratory problems, only the posterior expansion can solve those problems. So this kind of discussion is very interesting because there is no a receipt. You know, you can discuss with your team and to decide at each time what is the best of that patient. There is no a rule. There is no of course, you can see protocols, you can see guidelines in every paper, but the most important is to understand the disease and to discuss with the team to check in your institution, your experience with each procedure to decide step by step. So hydrocephalus, for me, it's a very complicated situation. Fortunately, it's not so many patients that present a hydrocephalus or progressive hydrocephalus. But of course, in my opinion, ETV, if I had a chance, if the anatomy permits, and then posterior expansion could be an option, and finally a VP shunt. So it's my opinion.
That's great. Thank you very much. Back to Dilip.
Yeah, Deepak, how much time do we have to?
No, we don't have time. We are running out. We'll ask for 4 more speakers because we have got Girish Solanki and we got Dr. Alin from USA. I'm sure they must be having some other commitments also.
That's fine. Let's move on to the part 2.
Then we can have some remaining discussion later on as the time permits. Okay.
Yes.
So next I call upon Dr. Girish Solanki. He will be talking about Chiari and syringomyelia and craniosynostosis and the revolutionary approach of doing a posterior calvarial augmentation. Dr. Girish Solanki is a consultant neurosurgeon at Birmingham Children's Hospital, England. He's a keen educator and he's involved in the neurosurgical training program director for pediatric neurosurgery over the last 10 years, as well as the chairman of West Midlands Region Neurosurgical Specialty. He is in the faculty for the courses by the European Society and by the International Society for Pediatric Neurosurgery. He has published within the areas of neuro-oncology, spinal surgery, craniofacial, and many more. And he has over more than 1,770 citations. Dr. Solanki is deeply committed to the advancement of pediatric neurosurgery, more so in the developing nations. Over to you, Dr. Girish.
Thank you, Deepak. You flatter me. I didn't realize some of the things you told me. But yes, it's a great privilege. And I wanted to thank my friends in the Indian Society for honoring me with this invitation. I was a bit flabbergasted to see the words revolutionary. It probably would be easier to say evolutionary. But yes, I think Chiari and syringomyelia is an important topic in craniosynostosis, and it gives me great pleasure to talk to you about what we've been doing in Birmingham and of course in the UK as well about posterior calvarial augmentation. Now, I was really, I found very educational all the previous presentations. So again, as Desi said, we might find that some of the slides and the topics that I'm going to talk about, you have already heard, but repetition often reinforces some of the important topics. So let me proceed. Let me see if this moves forwards. Yeah. So this is our old children's hospital. Is a nice old building, but there's a lot of activity going on. And I remember, Deepak, in 2012, I put this slide because this was the slide that I put in when you and the Indian Society invited me to talk on the posterior calvarial distraction. The title was Managing Intracranial Hypertension in Syndromic Craniosynostosis, and the report on neotechniques. And of course, the other neotechnique was rods and springs. So it's with deep affection that I remember that visit to Delhi. Of course, the standard techniques for surgery in craniosynostosis include the anterior, or what we call the frontal orbital advancement. You heard that the other technique that increases the intracranial size in craniosynostosis is monoblock procedure. quite difficult, and particularly so in infants, where we really want to increase the intracranial volume very quickly. And Ajay has made reference to that. And then the fixed posterior calvario augmentation, which is the newer technique that is coming into play in the last 20 years. So you've seen how the frontal-orbital advancement is done. It basically pulls the face. This is the monoblock distraction. It pulls either the frontal bone or the whole of the frontofacial segment and creates space in front. But the difficulty with this is that the part of the brain that we want to decompress is in the parieto-occipital region, and that part remains compressed, particularly in patients with brachythurecephaly. So this is why, in children with conditions like Pfeiffer's, monoblock distraction only releases the significant problem they have anteriorly, which is proptosis, orbital proptosis, and airway problems. But there is some remaining intracranial volume constriction that still requires treatment. You can see some of these patients, and Desi and others have dealt with this. So I'm not going to spend any time on that. But what I wanted to tell you is that we are shifting from the primary treatment in raised intracranial pressure from the frontal orbital advancement to posterior cranial vault surgery. And that can be in many ways. And it's really in the early 20s that we started it, and now I think it's well established. So specifically, when it comes to Chiari malformations and craniosynostosis, these are the significant 4 conditions where Chiari malformations have been recorded. And Kleeblatt-Shadel, of course, 100% of them will have it, but conditions like oxycephaly and Crouzon's will also have a significant contribution, and Pfeiffer's, of course. Apers, on the other end, they have the significant brachythurecephaly, and actually the cranial expansion goes in the direction of the anterior fontanelle. So very few of them actually develop Chiari malformation. It's an interesting concept. So this is a study we carried out at the Children's Hospital in Birmingham, looking at a group of controls, Chiari 1, Chiari 2, and craniosynostosis, particularly looking at how many of those have syrinx. And we were quite amazed to find, and this, of course, 20 years ago, hardly anybody did MRI scans on craniosynostosis patients, that 1/5 of our patients had a syrinx. So treatment of Chiari and syrinx in craniosynostosis is certainly something that we need to think about. And then my colleagues from Oxford, Jay and colleagues, did a very significant study on the abnormal venous drainage in synovial craniosynostosis, and they identified the significant problems with the vascular hypertension, particularly venous hypertension. And you can see on these images the significant venous component, erosion of the bone, and doing surgery in patients like this can be not just life-threatening, but sometimes associated with death. So it's critically important that patients like this are treated in centers of excellence with a large experience in craniofacial or craniosynostosis surgery, and certainly with the adequate anesthetic, vascular precautions as necessary. We also did some studies on the foramen magnum, and what bothered us is that in our study, what we found is that the foramen magnum in patients was quite capacious. The sagittal diameter in Chiari 1 and Chiari 2 was actually larger than in normal patients, suggesting that the problem wasn't space, but probably some degree of craniocephalic mismatch. And more studies started coming up in the early 2000s, suggesting that there probably is a component of a supratentorial crowding, which reduces the posterior fossa volume, and then evidence that skull-base anomalies like the clivus, occiput, and dens could also reduce the posterior fossa size and shape. And finally, that the foramen magnum actually is enlarged and does not need any further enlargement. So foramen magnum decompressions in craniosynostosis patients is probably unwarranted in the majority of cases. And then further data came out from Professor De Rocco and Francesco Velardi. And I always remember this very early presentation of patients who had acquired Chiari 1 malformation. And that Chiari regressed when Professor De Rocca carried out a supratentorial cranial enlargement. And this is the basis of craniocephalic disproportion theory, which we know applies to secondary cranial synostosis from shunting, but also very, very much appropriate to apply it to cranial synostosis. So when you see a patient like this, you have no doubt that this patient is raising intracranial pressure, and that the solution to that is to increase the size of the skull. So there will be very little in terms of argument. But also look at this. This is a child with Crouzons, and within 3 months, the child went from having this initial shape to significant cranial synostosis affecting the sagittal, essentially pansynostosis, so all of the coronal, the lambdoid sutures disappeared. And within 3 months, there's severe compression, which is mostly posterior. So in a child like this, a posterior calvarial expansion would seem absolutely appropriate. Look at another child. This is a child with Pfeiffer's, and look at the severe cranial synostosis with bulging. That is basically herniating brain in that area. And when you decompress the skull, this is what you find. Now, in those situations, it is absolutely appropriate that you consider a posterior calvarial surgery to decompress this child. So they have this typical cleavage shadow appearance, the trefoil. This is another example. This is pre brachythoracephaly, severe parietal occipital compression, severe bitemporal narrowing, and this is the postoperative appearance. So it is important that we address our targeted surgery in the part of the skull which is most compressed, so that we can obtain maximum cerebral decompression rather than just the aesthetic or anterior frontal decompression. Here's another example with severe venous hypertension, with severe bone, what we call a bone keel. So this is quite typical in patients with venous hypertension. You get this massive lumps of bone. And now in a situation like this, with a very small posterior fossa, it is only credible that you carry out a posterior augmentation. And of course, the presence of syrinx. Here's an example of a child with syringomyelia, pre and postoperatively. So all of this kind of led us in the direction of posterior skull vault expansion. This is the example of raised intracranial pressure in a child with cranial synostosis with lots of diploic vessels. And then, sorry, my apologies. And then after surgery to decompress a posterior skull vault expansion, you can see the reduction in intracranial pressure. So there is good evidence to support that a posterior calvarial augmentation is the appropriate procedure in cases where the brain is compressed posteriorly. That means raised intracranial pressure, the presence of a degree of ventriculomegaly, Chiari, and syringomyelia. So those are, for me, definitely indications for primary posterior calvarial surgery. Frontorbital advancement would be applicable to those children who do not have the severe brain compression posteriorly, but require cover or expansion of the airways. So those, I think, should be something for us to consider. So again, I come back to the point. So when to distract posteriorly? And I think it's important that we have some clear targets. And one target, Desi is referred to, and it's been referred to others, is in syndromic cranial synostosis. The biggest problem these children have is raised intracranial pressure. So particularly in Apert, Crouzons, and Pfeiffer's, you're going to find patients coming in with erosion of the bone, copper-beaten appearance, and those patients have raised intracranial pressure. You don't have to measure their pressure, it is elevated. And those patients require calvarial surgery that expands the skull to the point where they can relax the brain. There's lots of studies pointing to this. I won't spend too much time with this, but you've all surgeons, craniofacial surgeons are very accustomed to seeing pictures like this. And the more severe the compression, of course, the more important it is to carry out a more expansive calvarial decompression. So copper beaten appearance, bone that is so papyraceous, so paper thin that putting screws or doing anything in these children is critically difficult. So in those situations, particularly in infancy, even releasing the bone without applying any metal plates or screws, it's fine. So the second indication for me is what I call, so the first one, raising cranial pressure. The second one is Chiari and ventriculomegaly. They often go hand in hand in craniosynostosis because what happens is as the Chiari progresses, the foramen of Luschka and foramen of Magendie block up and you start getting progressive ventriculomegaly. So conditions like Klibat-Shadel, this is a Klibat-Shadel case, pansynostosis or brachyturicephaly, small posterior fossa ventriculomegaly, sorry, this was a lecture I gave to the French. So half of it is in French. I forgot to change the slide. But yes, ventriculomegaly and hindbrain hernia. How do you define a Chiari? So, well, Chiari, you define it according to Barkovich, which pretty much kind of set the tone in 1986, descent of the cerebellar tonsil more than 5 millimeters below the foramen magnum. And you can see in these pictures that this is a normal situation, but as we go towards the right, there is more compression, loss of CSF, and then there is this very gentle curvature of the craniocervical junction, as if somebody's punching the cervicomedullary junction from behind, and this compression then starts creating what we know as foramen magnum syndrome. So what we hypothesize, so we know actually from embryological data, from analysis of our patients, that in Chiari and syringomyelia, there is a small posterior fossa. That means there is a mesodermal anomaly that affects the skull base, and the height and the volume of the posterior fossa drops. You get a short stubby clivus. You lose the fourth segment of the clivus. You get a long elongated dolichoid. So the amount of the cerebellum within the skull reduces, and some of it slips down into the cervical spine. And then Chiari and syringomyelia on its own, even with a small posterior fossa, should not be progressive. So the progression means that there's something driving it, because Chiari and syrings are not tumors, so they shouldn't be growing. If they're growing, there must be something driving them. And this is what to say and hypothesize that it must be supratentorial crowding, which as the child gets older, the crowding gets worse and the hernia gets worse. There's more compression of the foramen magnum, and syringomyelia, which is basically the effect of a strangulated hernia, becomes more evident. And what are the features on radiology that tell us that this patient may have supratentorial crowding? So I've highlighted some of them here. The tonsils start losing their normal shape, become more elongated. The effacement of the CSF at the foramen magnum is one of the critical or statistically significant changes when you are likely to develop a syrinx. A flattened occipital bone. So the occipital bone is no longer curved. It becomes a straight, flat occipital bone. A steep tentorium. So the angle of the tentorium is no longer obtuse. It becomes more acute, nearly vertical. Venous engorgement, cervicomedullary kink, standing up cerebellum, occipital lobe, which lies posterior to the cerebellum. As you know, in a normal situation, the occipital lobe lies above the cerebellum, separated by the tentorium. In these children with craniosynostosis, the compression is so severe, the posterior fossa is so small that the occipital lobe ends up lying behind the cerebellum. So all of those features kind of tell you that this patient has supratentorial crowding. And if there is supratentorial crowding, what is the effect on the crowding of the brain? So this pictorial comparison tells you. This is a normal situation here on the left-hand side, and you can see the line from the posterior clinoid to the inion. Nearly half of the cerebellum lies above it. The tentorium is in a slightly oblong or sort of obtuse angle. But as the Chiari and the small posterior fossa develop, you can see that the line from the posterior clinoid to the inion, while remaining the same, nearly a significant portion now of the supratentorial compartment is where the posterior fossa should be. And this is because the obtuse angle of the tent allows the occipital lobe now to lie behind the cerebellum. And as it continues, you can see that the cerebellum now is actually pushing and curving the cervicomedullary junction. And nearly all of the cerebellum is above this posterior clinoid inion line. So more and more of the occipital lobe is causing the supratentorial crowding into the posterior fossa. So the amount of volume that the posterior fossa has lost can be calculated. So that bit there, where the occipital lobe is lying behind the cerebellum, belongs to the posterior fossa. And if it was there, there would not be any tonsillar herniation or any compression of the cervicomedullary junction. So this is what we call a supratentorial crowding. And the studies that we carried out, I pointed this out before, in Chiari and Chiari 2, the foramen magnum is actually large. So that is another condition that creates a hernia. If you have an incompetent hernial orifice, you're going to get a hernia. So making the hernial orifice bigger is not going to cure the hernia, it's going to worsen the hernia. So this is how we started getting the insights on the pathology of hindbrain hernia, and the idea of actually decompressing the skull and creating more space in the skull came from. And let me give you another way to describe this. So here's a normal MRI of the brain, an MRI of the brain in a child with syndromic pansynostosis. What we see here is a degree of brachyurecephaly. In a child with brachyurecephaly, the ventricles are flattened anterior posteriorly. If you superimpose them, you can see that the yellow area is the area that has lost volume on the child with brachyurecephaly. The child has increased, to compensate for that, the child has increased in height, so you get a bit of turecephaly. The ventricles have compressed, and there is loss of CSF in the sulci in the occipital region, which I will show you just now. And then the brain growth then has to adjust in the opposite direction. So if you lose space behind, your brain growth is going to go in the opposite direction, and often you get that. So what is our approach? What we need to do here is to reverse it back to the normal shape of the brain. And that means to augment the posterior fossa. And that's the intention. So we started doing this way back, my predecessor, Tony Hockley, and his colleagues, Mike Wade and Tony Golden. So they started doing something they referred to as a Jewish cap. That means cutting the parietal occipital bone and leaving it in place. So this was, we started about 1984. By 1992, they presented their original findings, and my colleague Spiros Gouros was the primary author of that paper. And then that pretty much continued until I arrived in 2002, 2003. And at that point, we started doing fixed posterior calvario augmentations. And by 2006, we had learned to do calvario distractions. And I would like to talk to you about the augmentation and distraction. This will be the sort of the basis of my talk from now on. So this is, again, a pictorial demonstration of what the augmentation is that we make a melon slice cut in the parietal occipital region, and then we move that backwards and we plate it. So this is just a posterior parietal occipital augmentation. Often this is not adequate in syndromic synostosis because they also have sagittal synostosis. And what you need to do in those situations is to increase the lateral expansion in these patients. And this is, I think we missed one slide, but this is, let me just see if I can get it back. Yeah. It's disappeared, but I can show it to you on the X-ray. You can see that here the parietal plates have been barrel staved. So in multi-suture synostosis, you do have to account for the narrowing or scaphocephaly. And in these patients, doing parietal plate and occipital plate expansion and then pushing them backwards and then securing them with plates is what we do. So this is intraoperative images. This patient actually had a shunt as well. So you have to protect the shunt by leaving a piece of bone around the shunt so that the shunt is not disrupted or disturbed. And then a parietal occipital, posterior parietal occipital, and 2 biparietal plates are cut, barrel staved, and then the central area, which there's a kilo of bone usually compressing the posterior sagittal sinus, is then released, and that then allows us to put everything back. And at this point in time, we were using resorbable plates, which you can see just here and there. These are resorbable plates, but the resorbable plates were not very effective because they used to buckle. And then ultimately we changed this into fixed titanium plates, which have a much better result. So this was the initial procedure that we carried out. And as you can see, this is an example of a complication where the skin didn't close very well, the plate buckled, and we subsequently discontinued the use of resorbable plates in these cases and went to a rigid distraction. And so the rigid distraction really started with the very small telescopic distractors, which then came out through the skin. I will show this in detail a little bit later on, but the idea was that we would do a bicoronal incision, make a melon-sized cut, but don't separate the bone from the dura, and gradually start distracting it over a period of time. This is the basic telescopic distractor. It's a mandibular distractor that we started using very much right at the beginning in 2003, 2004. And onwards, and by 2006, we established our technique. You can see in this patient, this is the cut is over the line here. The front is usually around where the coronal suture or just behind the coronal suture. And we try to go below the torcular so that the posterior fossa is augmented as well. And then the direction of the augmentation is about 5 degrees upwards to increase the size of the head. And you can see over a period of time, the bone, you get osteogenic distraction, and the bone sets in the gap. And you can see the angle of the distraction. Initially, we started with 4 distractors, then went to 3 distractors, and now we simply use 2 distractors. So experience teaches you what are the limits of your structural construct. And I think at the beginning, we were quite worried that we might cause problems, particularly in thin skull. But as we learned how to do this, we now only use 2 distractors. And you can see as time goes by, the bone, we expand the bones and the new bone sets in the gap. And this is another picture of the latency distraction, and then during consolidation, new bone sets in. And it's really good to see how we can actually make the shape of the skull more normal in these children with an amazing increase in the calvarial size without ever entering the dura. This is new bone formation confirmed histologically on a patient that we had to go back to remove the plates. We took a small biopsy of the bone. So this definitely was something that we were really, really impressed with, and we have continued to do this in most of the syndromic craniosynostosis. On the MRI, you can see the effects significantly better. This is the pre-op and post-op scan, and you can immediately see that the turicephaly is decreased, that there is CSF on the sulci in the occipital lobe, and even though the ventricular size is still large, there is a much better shape of the ventricles. So this is CSF on the sulci, and all of that makes for much better sort of a brain, much more relaxed brain, and hopefully better brain function. So we published our initial data in 2009 on Charles nervous system. This was very early data. We only had done about 6 patients, or we had data on 6 patients. Of course, now we are around 75 cases. And Desi is leading on this now. He's our senior craniofacial surgeon. So the technique is well known, has been well described. Our telescopic distractors have changed over time. We only use 2 of them. And basically what we do is we start distracting 1 millimeter per day. After 4 weeks of distraction, we get about 2.5 to 3 centimeters of distraction. Distraction is then held in place. And then once we are sure that the distraction is fine, then the plates are removed. Very rarely, the plates may have dug so deep that we leave the plates and screws, but the telescopic as part of the distractor can be removed. You can see that again. So I'm going, this is the photographs. This is a particular child that did very well. You can see the severe brachyurycephaly. You can see the distractors. This child had 3 distractors. You can see one at the top there. And then this is the final appearance at 3 months when the distractor is removed. So what are the effects of posterior calvarial augmentation? So the first one, of course, is the correction of the skull vault deformity, particularly in cases of brachycephaly or brachyurycephaly. I think that is the ideal indication for this procedure. From the point of view of a neurosurgeon, the significant reversal of raised intracranial pressure, and then also correction of central apnea and improved apnea-hypopnea ratio on those patients that had compression of the foramen magnum and cervical medullary dysfunction. Resolution of headaches, this is pretty much a universal feature. And for those patients who had Chiari or syrinx, regression of the hindbrain hernia or deflation of the syrinx, and an increase in the posterior fossa surface, which we have measured ourselves, either by volumetric measurements or surface area measurements of between 7 to 15% increase, and up to 35% increase in the skull vault surface area. So clearly, this is a procedure that in syndromic or pansynostosis can be very helpful. But not just. In cases of non-syndromic craniosynostosis like pansynostosis or lambdoid synostosis, it has, because it's posterior, it's quite effective. And then any synostosis, doesn't have to be syndromic, with Chiari and syrinx could also respond positively. And then those patients with the tight foramen magnum central apnea could actually respond to a calvarial augmentation in specific cases. Now, before you do a posterior calvarial augmentation, we always say that, and Desi and Ajay have highlighted this, that if you have coexisting hydrocephalus, you need to consider doing something. Especially in those patients with significant ventriculomegaly, my preferred option is to consider an ETV, and those that have severe craniocervical instability, I tend to fix that first by carrying out a spinal fixation, if appropriate, before the posterior calvarial augmentation. So these are some tips or pearls to remember. Multiple studies are coming out. I think the first one that came out was by Richard Ellenbogen and Jeffrey Ochman, and they, just like us, reported resolution of syndromic craniosynostosis associated Chiari malformation type 1 without suboccipital decompression by simply doing a posterior cranial vault release. So I was really pleased to see that coming from a group of neurosurgeons. Upfront suboccipital decompression may not be necessary in craniosynostosis with Chiari 1. A strategy of initial cranial vault release followed by watchful waiting and radiographic surveillance is proposed. So this was, I think, for me, it was very pleasing because somebody outside of our unit was saying the same thing. I think that was the first one. And then, of course, many followed. My friends and colleagues from Oulu in Finland, I think were the very early adopters of our posterior cranial vault distraction, osteogenesis, and they've got a nice series which has replicated our findings. My friends and colleagues from France, Federico De Rocco, both Tatiana, who's now in Rio, so they also did a very similar approach, and they found also that the posterior cranial vault distraction is an efficacious technique to enlarge the posterior skull vault and increase intracranial pressure. It also appears to be efficacious in treating hindbrain hernia-related symptoms. So they found the same thing. So more and more, I won't go into the whole literature review, but what I can tell you is that since then we've continued with the procedure. I can tell you personally that not everybody liked it. There were some detractors of the posterior calvarial augmentation. My own practice was investigated, and then when the results were reviewed, it was clear that there were significant benefits. So from 2003 to 2019, we have done about 35 of these posterior calvary augmentations, so we're pretty selective about this. In syndromic cranial, about 40% of these procedures have been done in syndromic cranial synostosis, but we have found that the procedure is also helpful in non-syndromic cranial synostosis, Chiari-1 and syrinx related conditions. And that includes non-cranial synostosis Chiaris as well. And when we talk about dynamic posterior osteogenic distractions from 2006 now to 2019, about 75 cases have now been done. And the two main indications include syndromic cranial synostosis and non-syndromic cranial synostosis with a variable percentage depending on the conditions. And then finally, more recently, I think the paper was just published last year, posterior calvaneal distraction in complex cranial synostosis, Chiari-1 and syrinx, a 10-year experience, which indicated that the procedure is helpful in patients both in regressing the Chiari-1 and in deflating the syrinx. So of the, there were 10 patients, so total number of patients with the syringomyelia was 16. Of those, we had 3 patients out of 4 with the syrinx improving or deflating the syrinx entirely. So of the 16 patients, 9 improved their syrinx, 7 remained stable, 0 worse. This is an illustrative example. Here's a child who had a posterior calvaneal distraction. You can see the distractions before and after. This is the MRI scan showing significant venous hypertension and sinus pericranii. You can see the Chiari, the syringomyelia, and post-surgery, the decrease in venous hypertension and regression of the hindbrain hernia, as well as a complete deflation of the syrinx. So this is the pre-op syrinx, which is nearly a hollow cord syrinx. That's the augmented image, and this is the post-operative deflation of the syrinx. And this is, of course, without doing anything to the foramen magnum, simply increasing the size of the skull through a posterior calvaneal distraction. Of course, no procedure goes without complications, and this one in this series of 75 patients, 9 patients had complications, 3 had CSF leak, 3 wound infections which were superficial, but 2 of them required termination of distraction because the wound was right on top of the distractors. 1 was treated conservatively, and 3 related to distractors themselves. So in this series of distractions, you can conclude that the cranial vault expansion following posterior calvaneal distraction also includes an increase in the posterior fossa volume, that the Chiari malformation improves after the distractions, and that the posterior calvaneal distraction is safe and effective first line for concurrent cranial synostosis and Chiari with or without syringomyelia. And that pretty much certain to us that the Chiari malformation is a manifestation of insufficient intracranial volume. This is, I hope the video will run. It's a very simple video just to show you how easy it is to do the distraction.
The cat is saying, naughty cat, naughty cat. Is that a cat saying that? Oh, wow. Oh, wow. Okay. So, Mom, so this bit goes on the side, yeah? So you hear the click when it went on there? Okay. Yeah. So this bit is pointing this way. Okay. This bit here. And these two are clockwise. Bending. Turning clockwise. 360 degrees, no resistance. There we go. And we start here again. Okay. That comes off. See, Aisha told you.
So you can see we are showing Mom how to do the distraction herself. And once moms learn how to do the distraction, they do this at home. So the child is discharged home and the parents do the distraction. And then after the standard 23 days or 30 days or 3 weeks, depending on how we do it, they come back and the distractions are then removed. Okay, so there is one complication of a distraction that can be difficult, and we've identified this complication as gull winging, because it looks like the wings of a seagull. And what happens essentially is that if we start a distraction, but the lambdoid suture is patent, then the central part, so you can see here, this is a distraction going on. You can see a nice flat of the parietal occipital bone being pulled back, but you can see that there is an angulation. The central part doesn't seem to be moving as much as the lateral parts. And I think you can see it better here. And what happens here is that, unfortunately, the lambdoid suture is patent. So the parietal plates move back, but the central plate where the lambdoid suture controls it stays in the same place. And that causes this typical appearance. This is another patient. And of course, that essentially just delays the expansion and can make a wide sort of flange appearance of the lateral aspects of the distraction. And you can see what's happening here is that as the bones are being pulled back, the central part, which is behind the lambdoid suture, particularly when the suture is open, does not get distracted backwards. In fact, the pressure of the skin keeps it in position, and that causes a curvature and the gull winging appearance. So this is the mechanism of formation, and you find that the central part hasn't expanded. So one potential treatment of that is to put plates around open lambdoid sutures to ensure that the central part of the occiput moves with the distraction. So I'm just going to conclude here now and say that chronic hindbrain hernia in children requires appraisal of alternative therapies behind the occipital craniectomy that you'd normally do for a Chiari-1 hernia. And in children with craniocephalic mismatch, we recommend a calvarial augmentation. And that is pretty much all of the craniofacial children. In children with craniocervical compression, they may also require brain stem decompression. Either posterior calvarial augmentation or distraction are effective in the management of raising the cranial pressure in craniosynostosis associated with craniocephalic mismatch. And they improve the radiological appearance in a number of features, particularly more space around the brain. That is definitely seen on MRI scans. There is reduction of the Chiari type hindbrain hernia in the vast majority, 80 to 90%. Deflation or reduction in syrinx size in 75% of the cases with syringomyelia. And I'm going to stop here now and thank the Society again for your kind invitation. And like to thank the craniofacial department, Desi, of course, my buddy, and the craniofacial colleagues, the craniofacial fellows and neurosurgery trainees who have toiled to get all the data that I presented here today. So thank you to all of them. And of course, all of our patients. Thank you.
Thank you, Girish, for a wonderful talk. I think it's 8 o'clock. Something is there at the clock. I think we'll move on. Next, we have a very eminent speaker and a surgeon par excellence who was introduced to me by Dr. Sandeep Sood, who is an ex-Amazonian. I request Professor Dr. Aline Rosale. She is the Chief of Plastic and Reconstructive Surgery at Children's Hospital of Michigan, Detroit. She's also the professor, clinical educator in the Wayne State University. She did a fellowship from the Washington University School of Medicine in the craniofacial pediatric and plastic surgery from the St. Louis. She has received various awards and various honors. She received almost for 10 years our Detroit Magazine's annual Top Doctors Award for Pediatric Plastic and Reconstructive Surgery between 2009 to 2018. And I'm sure she's going to tell us a little bit about this Sanchez Little Smiles, which she is a part of, and which provides a very social cause to the families and the opportunity to the people. And I think she will tell us something about it after her lecture to us. Ma'am, over to you. You need to unmute. Could you please unmute? Yeah. Okay.
Let me big screen again. Big screen again. Here's your PowerPoint. My PowerPoint is right here. My PowerPoint's right there. Okay. And I guess I want to do slideshow, but I got to share the screen. What's happening? Yeah, this is why I was worried. Give me just a second. Go back to Zoom. Okay, share screen. Okay, and we're unmuted. And there you go. Okay, I hope I can do this right. Dr. Maraputi is helping me play
Hi,
from
Dr.
start. Okay, hi, good evening to you all. Thank you for inviting me. We're here in Detroit today, and I'm going to talk about distraction, but somewhat more from a plastic surgery point of view. So just first of all, you all know this is the shape of a normal skull, and especially from the plastic surgery point of view, the maxilla and the mandible are anterior to the skull, and that's what we're trying to achieve. And again, this is what a baby with a normal skull shape looks like, with an egg-shaped skull. And again, the face, the mandible is anterior to the skull. And you all know the very rapid growth phase in the first year of age, which has impact on what surgical procedures we're going to choose. Again, craniosynostosis, a lot of this has been gone over by the excellent talks already. And the syndromic craniosynostosis that we're discussing today, of course, Apert-Cruzone's, Pfeiffer's, Sathray-Chudson, and others. And in syndromic craniosynostosis, the children almost always have maxillary retrusion, exophthalmos. They're at risk for developing posterior fossa compression and Chiari, and especially when they have multi-suture synostosis with the oxys tetracephaly or Kleeblatt-Shotto cloverleaf skull. This is my skull library. Dr. Marsh, who was my mentor in St. Louis, they were at Mallinckrodt radiology department. They were some of the first to do 3D craniofacial CTs, and medical modeling made a whole library from Dr. Marsh's patient population. Okay, just very briefly, a lot of this has been gone over already. Cruzone's disease, you usually have bicoronal synostosis and midface hypoplasia. And as many of you have mentioned, kids with Cruzone's usually do very well. And as a matter of fact, some of them are not even diagnosed till they're older because they have a more mild dysmorphology and they're doing well. Apert syndrome, of course, bicoronal synostosis, maxillary retrusion, exophthalmos, and they can have a cleft palate. They can definitely have hearing deficits. And these are the kids who have the symmetric complex syndactyly of their hands and feet. So here, for instance, is this little girl. She has Apert syndrome, bicoronal synostosis. You can see her fronto-orbital rim is posterior to the orbital area, and she has maxillary retrusion. And here is her mitten syndactyly of her hand and her feet. And here is showing someone who's had the hands surgically corrected over multiple surgeries. And then also, in some cases, the orthopedic surgeons do have to do surgery on the feet. And actually, I don't have a picture of it here, but in some cases, they actually distract the first toe to get it into the appropriate position. Okay, Pfeiffer's, as was mentioned previously, there are multiple different mutations. So there's different severity of Pfeiffer's 1, 2, and 3. And usually there's at least coronal synostosis, but these are the kids who often have multi-suture synostosis and the cloverleaf skull, and they can also have hand anomalies. And again, here's an example of a little guy with Pfeiffer's, born with a cloverleaf skull with multi-suture synostosis, with partial coronal, sagittal, and lambdoid. He had broad and deviated thumb and first toe. Another little guy with Pfeiffer's, again with cloverleaf skull, and you can see the very severe pterocephaly and recession of the frontal orbital area. And this is why it's called cloverleaf, because on the axial cut on the CAT scan, it looks like a cloverleaf. Carpenter's autosomal recessive, again, usually multi-suture with possible syndactyly. Again, here's a kid who had soft tissue syndactyly corrected with surgery. And then Sathray-Chatson, these kids can have coronal synostosis, though I've had multiple patients who genetically had Sathray-Chatson but no synostosis. And it's they have a very significant low set anterior hairline and ptosis. So they generally have this appearance of the ptosis and the low set hairline. And then just again, briefly, the Kleeblatt shadow, the cloverleaf stall with multiple suture synostosis. These kids can have significant exophthalmos and usually have significant mid-face protrusion. So historically, again, this was already nicely gone over by one of the previous talkers. 100 years ago, neurosurgeons were doing strip craniectomies, which had plus minus results. And then in the 50s, Dr. Tessier and then his trainees developed a more extensive frontal orbital advancement in cranial vault remodeling. You showed the Marshak-Renier. And then strip craniectomies, but used with a molding helmet post-op, became repopularized in the 1990s by Jimenez and Barone. And then, as was previously mentioned, in the early 1990s, Dr. McCarthy published on doing mandibular distracture in more school-age kids for hemifacial microsomia. And then Dr. Pauly from Chicago published on doing mid-face distraction, especially for kids with clefts. And then people began to say, well, if we can distract the face and the mandible, perhaps we can distract the calvarium, because we had been doing monoblock distractions. So current surgical procedures are varied, and I think we obviously have to evaluate each child and customize the procedure to that child's needs. And from a plastic surgery point of view, we do follow them till they're in their 20s, and some of the kids long-term are going to need maxillofacial surgery, LaForte advancements, possible rhinoplasty, orbital repositioning, and then secondary surgeries, for instance, for contour defects in the skull using either bone cement fillers and so on. Okay, urgent surgeries were already discussed. And again, as was previously discussed, we want to try to avoid doing tracheostomies if we can, because they do have lifelong implications. In some children, a monoblock advancement may be the best solution. Using nasal stents was mentioned as a possible solution, or opening a stenotic nasal passage using CPAP. In our practice here, we do have a multidisciplinary team that evaluates the child. We do, if they're stable enough, we do a sleep study. And then I also, in concert with ENT, do what we call a sleep endoscopy. We give them mild sedation, and I do a nasoendoscopy to see what level the obstruction is at, whether it's at the nasal level, plus minus the base of the tongue, plus minus any lower airway anomalies involving the larynx, the trachea, et cetera. And that can give us some data to go forward in what would best help the child's airway. And then, of course, if they have exophthalmos and corneal exposure, short-term, you can do taping, they can have a tarsorrhaphy, and then if needed, either a frontal orbital advancement or monoblock, and I'll show examples of that. Okay, so from a plastic surgery point of view, when we started doing mandibular distraction in the 1990s, it was just a game changer for us because we could operate on kids much earlier. They got excellent bone growth with excellent results. And then also the same thing with maxillary distraction. I'll show you some examples of this. So I know this is not the skull, but these are some babies who have cleft palates and Pierre-Robin sequence where they have very small jaws. This baby has a very small jaw. You can barely see anything here. And when she presented to us at 2 weeks of age, we did a sleep study that night. and her apnea-hypopnea index, her AHI was 101 per hour. The very next day, I did a mandibular distraction on her. And then I usually leave the distractor in 4 to 6 weeks. This is after the distractor was removed. And then her post-op AHI was 0. So this is a mechanical problem, and you're having a mechanical solution. And here's a picture showing what the CAT scan looks like pre-op. Because the mandible is small, it pushes the tongue back into the oropharyngeal area, blocking the airway. And then when you advance the jaw, the tongue comes forward and opens the airway, and babies are bone machines, and they fill in bone almost completely within 4 to 6 weeks before we remove the distraction device. Now, Lefort distraction, again, in the plastic surgery craniofacial world, again, this has been a game changer. In the old days, we had to wait till kids were in their skeletal maturity to do their Lefort advancements. We had to use bone grafts. And when you do a Lefort advancement where you're moving the maxilla forward, historically, when we were doing that in a one-stage operation, you could only move it forward about 10 millimeters or so. But now with distraction, you could move it forward 20 millimeters, 30 millimeters, as much as you want, and get a good result. So again, just to reiterate, the Lefort 1 distraction is just the maxilla coming forward. If you include the nose and the maxilla, it's a Lefort 2. The Lefort 3, we include the orbits up to the frontal-orbital bar with the maxilla and bring everything forward. Though in some cases, you may want to do a Lefort 3 with a Lefort 1 as separate osteotomies, because you may need to bring the maxilla forward more than the orbits. And so you would have 2 distraction devices. And then, of course, a monoblock, you're bringing forward the whole maxilla, orbits, frontal orbital bar, and the forehead. So here's just an example of a young lady who actually had a cleft, and I'm using an external device, and I'll talk about the options of external versus internal in a moment, and had excellent result from bringing the maxilla forward. So rationales for distraction from the plastic surgery point of view. First of all, you can do an operation at a much earlier age than you could have in the old days when we had to do a one-step advancement. You can get incredible advancement of the bone. You usually don't have to then use a bone graft, because usually new bone grows in, at least in the face and the mandible. I've found that in the skull, if you do the distraction very early, you get good bony ingrowth, but later in life, the skull does not ingrow bone as much as the face does. The other thing is that the soft tissue adapts. As you're advancing the bone, the soft tissue is gradually getting stretched and growing so that it is not constricting the advancement of the bone. And so therefore, hopefully you get less regression. And then as the excellent talk we just saw, people then became enthusiastic about doing posterior vault distraction to allow delay of having to do the frontal orbital advancement, because you get a better long-term result in doing frontal orbital advancement when you can wait till the child's older, a year or more. And then also doing the posterior vault distraction gives you increased posterior fossa volume and can help improve or prevent Chiari, etc. Pros and cons, we just went over the pros, but the cons is I tell the parents, this is a process. It's not like you go in, you do the surgery one day and you're done. This is a process. The distractor is going to be in there probably a couple of months, and you can have multiple complications, which have been brought up already by the previous presenters, including device exposure, infection, CSF leak, malfunction, where you may have to go back and remove the device or replace the device. And now just for a minute to talk about the external device versus the internal device. An internal device is wonderful. It's hidden under the skin. Some people don't even realize the child has a distractor in. It's easier to use. However, it does not, it cannot give as much force on the bone especially if you're operating on someone who's already had surgery and there's scar tissue. And also with an external device, you can do vector control, which I'll show you in a minute, which is especially important when you're operating on the midface. So again, here's just an example of a X-ray with an internal device in for monoblock advancement with plates in the frontoorbital and maxillary region. And then of course the external device with the plates and wires coming to bring the maxilla forward and the frontoorbital area. And here's the defect in the bone. But with the external device, you can move the plates by the mid bar up and down, side to side. You can change the angle. So especially for the midface, this can be extremely helpful. And again, you can exert quite a bit more force by pulling the bone forward rather than trying to push it forward when you only have these small screws holding the plate in that very thin bone. Okay, so distraction and syndromic craniosynostosis. We already had an excellent discussion about posterior vault. It's been described for anterior vault movement, even in unicoronal synostosis, because again, you get the soft tissue can gradually adapt. So you might get a better long-term result. And definitely it's very helpful in doing monoblock advancements, Lefort 3, Lefort 1, and mandible. So some examples. So starting, here's this little boy, he has Apert syndrome. He had a calvarial reshaping when he was 6 months old, and now here he is at 6 years of age, and we were concerned about posterior fossa constriction and possible developing Chiari. So he underwent a posterior vault distraction. Here's the distraction screw coming out. Here's the intraoperative picture of what it looks like. And then here he is after his posterior vault distraction, and he still has significant maxillary protrusion, and he was having apnea and obstruction at the nasopharyngeal, oropharyngeal level. So we then did a monoblock distraction using an external device with the plates in the frontoorbital area and the maxillary area. And then here he is after he's had both his posterior vault distraction and his monoblock distraction. Here's another little boy who was born with Apert syndrome and had bicoronal synostosis with brachystereocephaly, exophthalmos. And though it's hard to see clinically, you can see on the CAT scan that he has maxillary protrusion. And he did have significant sleep apnea. His AHI was in the high 40s. And on scoping, it did appear to be obstruction at the oropharyngeal, nasopharyngeal level. So when he was 4 months old, I did a monoblock distraction on him using internal device. And here he is after the monoblock distraction. You can see the maxilla is now out anterior to the mandible where it should be. And because he was young, we got good bony ingrowth here. Here's another little boy who has Apert syndrome, and he was born at another hospital. So he didn't come to us till he was about a month old. And so he had already had a tracheostomy and tarsorrhaphy done to try to protect his cornea. So because we did not have to move quickly to treat his exophthalmos and his airway obstruction, we did proceed with a posterior vault distraction when he was 6 months old. So you can see here. And then at about a year of age, we came back and did a frontoorbital advancement. And then at some point, probably in the next 2 or 3 years, I will do a Lefort 3 advancement on him so that he can be decannulated. And here's his CAT scan showing his bicoronal synostosis, his maxillary protrusion. Here he is with the expansion device, the distraction device in. You can see because he is a little older, we haven't completely grown in bone here. And then here he is after the frontoorbital advancement. Okay, now moving on to Pfeiffer's, and as has been mentioned previously, these kids are so many more challenges. There's multiple issues going on. In many cases, they do have the cloverleaf skull, so they're going to have compression on their brain. They're at risk for Chiari, exophthalmos, and then maxillary protrusion and airway obstruction. So this is this little boy who was born with Pfeiffer's with a cloverleaf skull. Here, here's his CAT scan showing multisuture synostosis, coronal, sagittal, lambdoid, and severe copper-beaten or fenestrations actually of the skull. And as the previous speaker mentioned, going in and doing surgery on these, just even from reflecting the bicoronal skin flaps and then removing the bone is very challenging and tricky, and you can get dural defects. And I'm going to show the series of operations we did to the point where we did advance this child and also do a mandibular distraction. So here he was as a newborn. And when he was about 2 months old, I did a monoblock distraction on him, again, using an internal device. I think on a tiny baby, the external device would be hard to use because their bone is so soft. I'd be worried about getting intracranial extravasation of the pins. And so, and also, when I do the fronto-orbital, the monoblock distraction, I don't just cut the bone, we do a reshaping of the fronto-orbital area so that the relationship between the orbits and the fronto-orbital bar and temporal region will be a more normal appearance. So here he is after he had his monoblock at 4 months of age. He did 2 months of age, excuse me. He did very well till he was about 18 months old when, again, his airway obstruction worsened again, which was demonstrated on sleep study and sleep nasoendoscopy. So at that point, we did do a monoblock again with the external device now. And here he is after we did the monoblock with the external device. And once we got his maxilla out into position, you can see that actually his mandible is very small and he was still having airway obstruction. So we went ahead and did a mandibular distraction on him. Here's when the distractor's first put in. And here it is as we're distracting. And here he is after the mandibular distraction. You can see his jaw here, and his face has a very normal morphology now. And then he did go on to have a posterior calvarial expansion. Okay, here's another little guy with Pfeiffer syndrome, again, born with the cloverleaf skull. Fortunately, this child did not have significant airway obstruction when he was a newborn. So at 2 weeks of age, we did a calvarial vault remodeling where, as was just mentioned, basically we're going in, we're removing the bone, new bone will grow in. We're trying to just release all the constriction on the brain. And I put back whatever bone we do have and try to get as normal shape as possible. So here he was prior to the calvarial reshaping at 2 weeks of age. Here he is now at about probably a year of age. And you can see that the skull is significantly expanded, but he still has significant maxillary protrusion and exophthalmos. And so at 2 years of age, we did a monoblock advancement with an external distractor. And again, we go in and reshape the frontal orbital area and hold it in place with plates. And then the distraction device would have been in the frontal orbital area and the maxillary area. And I'll show you a picture of that in a minute. But what is so good about the distraction here is that here he is pre-distraction, here he is post-distraction. And look at the incredible amount of bone that has totally grown in the naso-ethmoid orbital area and also in the orbital roof, going from severe frontal orbital recession to good frontal orbital position with bone growth. Less so again in the skull at this older age. So here he was pre-op before doing his monoblock advancement. Here he is in the process of the monoblock advancement with the external device with the plate and wire in the frontal orbital area and maxillary area. And then here he is post-op a year or two later. And that's just again showing where the plates and the wires are. And then this is the last child I'll show in the early distraction cohort. This little boy had Antley-Bixler syndrome. He was born with his globes totally subluxed from his calvarium. You can see the maxilla is severely recessed. And so when he was a few days old, we went in and did a monoblock advancement on him. And because I was going to have to move the maxilla forward extremely more than the frontoorbital area, I used two devices, one in the frontoorbital area, one in the maxillary area. Here's his pre-op CAT scan. You can see the frontoorbital rim is behind the globe. The maxilla is behind the globe. The maxilla is very small. And then here he is after the distraction. Again, we've almost completely grown in bone in the orbital roof area, and significant increase in the volume and projection of the maxilla. And now we'll switch to, as the last topic, the later surgeries, which again, the neurosurgeon wouldn't be usually involved in as much unless we're doing a late monoblock. But we continue to follow these kids till they're in their 20s, and they may need orthognathic surgery, secondary frontal reshaping, or fillers, or even fat augmentation, and then in some cases, even mandibular distraction. So going from bottom to top, again, occasionally we find after we've brought their mid-face forward that actually their mandible now is small and needs to be brought forward. We already showed this patient. And then if they get into the either school age or teen years and they still have maxillary protrusion and it's affecting their airway, their speech, etc., then we do a Lefort 1, Lefort 2, or Lefort 3. And here's an example of a little girl. She had Pfeiffer syndrome, and she had had a calvario reshaping as an infant. And now she's 7 years old, and she has significant maxillary protrusion with exophthalmos and airway obstruction. And so we did a Lefort 3 distraction on her with an external device, and here she is afterwards. And then here's an example of a child. Again, we mentioned Crouzon's has significant variability in how severely the kids are affected. So this little girl didn't present to us till she was 2 years of age with previously undiagnosed Crouzon's syndrome, and she had papilledema and increased intracranial pressure. So we first did I actually did a monoblock on her when she was 2 years old. Here she is after the monoblock at 2. And then we're following her, and now in her teenage years, she's 14 years old, and she now has still maxillary protrusion and some contour defects here. So at 14 years of age, I did a Lefort 3 advancement, did some touch up of the zygomatic areas and frontotemporal areas, and did a rhinoplasty. And so here she is now after all her surgeries have been completed. And then here's another young lady who had previously undiagnosed Crouzon's syndrome, who presented at 12 years of age. So she's almost in skeletal maturity. So we were able to go ahead and do a monoblock distraction on her. Again, you see exophthalmos, maxillary protrusion. And I was able to use an internal device and bring it forward because I knew I could get both the frontoorbital and maxillary area adequately forward with one device. And here she is afterwards with a very nice facial contour. So in conclusion, distraction has been a wonderful tool. It allows us to operate earlier, get greater advancement, possibly with less regression, and get the soft tissue accommodates. And you can get excellent new bone growth, especially in the face, plus minus in the skull. But it is a process. We warn the family. There can be multiple healing issues, complications, and we just have to keep working to get the child to where they need to be. So thank you.
Thank you, Dr. Ellen, for covering the topic so holistically. We are really honored that you accepted our invitation at such short notice. Thank you so much.
Thank you.
Thank you. Next, I call upon a team, I would say, a team of Dr. Pramod Subhash and Dr. Suhas. Pramod, he's a very close friend of mine, and he's a clinical professor and chief of craniomaxillofacial surgery at Amrita Institute of Medical Sciences in Kochi in Kerala. He will be sharing his experience on mid-phase distraction in the very young, applications of robotics in craniofacial surgery. Over to you, Pramod.
Thank you, Deepak. Thank you so much for having us. I know it's getting late, and I will try to stick to the time that you have given me to the maximum. So it's kind of combined talk where I speak one spectrum and Suhas is going to speak the rest. I will concentrate only on mid-phase distraction in the very young. And it's just a place where we have off-label used robotics in craniofacial surgery. Even though at Amrita Hospital where I work, craniofacial surgery has been going on. Suhas and I started off as a team, say about six and a half years back. So since then, we have performed, the Amrita craniofacial unit has performed 220 odd craniofacial procedures, of which pediatric mid-phase distractions constitute 30. Of course, being India, we get much older patients in whom mid-phase distractions are performed. So that's our craniofacial team, includes pediatric neurosurgeon, then our wonderful pediatric neuroanesthesiologists, the plastic surgeons, and other colleagues. You will see that, one will be able to see that in this list, of the most common craniofacial syndromes. There is an involvement of orbit and midface in various kinds of severity. The most common being midface is very often involved, and of course the orbit is also involved, and the most common features that we can find is exorbitism, but of course ophthalmologic examination could reveal papillary edema. If long-standing, can lead to secondary optic atrophy. Severe exorbitism can lead to ocular subluxation and exposure conjunctivitis. Briefly, corneal exposure, if identified early, can manage with lubricants, eyelid taping, or adhesive cups. But if untreated, it can lead to loss of vision, as we have seen in other lectures. So temporary tarsorrhaphy is the first option. There is no adhesion, but it is just a suture that is placed between the upper and lower lids. In established corneal exposure, it may take about, we may need about 1 to 12 weeks of closure. So what causes exorbitism in midface? It is the shallow orbits, which is caused by midface hypoplasia and frontal protrusion. And is it only these? Not exactly. There is a compression of the lateral wall of orbit by the middle cranial fossa that expands antero-inferiorly, and there is a compression of the orbital roof by the inferiorly displaced anterior cranial fossa. So it is this pressure from the inside and the retrusion of the frontal bone and the midface that causes a significant reduction in the anteroposterior dimension of the orbit. This can lead to globe subluxation, and permanent tarsorrhaphy is a procedure that can be taken up as a immediate measure to prevent recurrent globe subluxations. Midface, the exorbitism caused by midface retrusion is more severe in common. It could, airway issues could be caused by choanal atresia, as mentioned earlier. It also can lead to constricted maxillary arch and contributed by mandibular hypoplasia. So what causes airway issues? The slow midface growth that arrests prior to 10 years of age. It results in short anterior cranial base with acute cranial base angle and a class 3 occlusion. Maxilla is constricted and highly arched in most of the syndromic patients, which constricts further vertical dimension of the nasal cavity. And add to this the normal development of lymphatic tissues within the Waldeyr's ring. All these factors put together leads to nasopharyngeal and oropharyngeal obstruction. So that's a child in whom we can see there is actual obstructive sleep apnea, where he stops breathing, and the maxillary arch that is very restricted. So the maxilla is underdeveloped in all three dimensions due to the skull-base suture synostosis, the position of the greater wing of sphenoid, and the recession of the frontal bone. There is a reduction in maxillary height and width, nasal cavity width, and bony nasopharyngeal height. It is the main risk factor for obstructive sleep apnea, but adenotonsillar hypertrophy and choanal atresia may also contribute. 40 to 68% of children with syndromic craniosynostosis have obstructive sleep apnea, and this poses a very serious risk of impaired respiratory function, cor pulmonale, and can even lead to sudden death. So earlier, though you have heard most of the speakers say that they would try to avoid tracheostomy. Tracheostomy used to be, and even in some centers it is practice, where tracheostomy is the first line to protect the airway. But we know that decannulation is prolonged in mid-phase issues, and in mid-phase issues it can be at an average age of 6 to 7 years, even though earlier decannulation is possible in mandibular deformities. We know that pediatric tracheostomy, if maintained for long term, is associated with significant morbidity and mortality, and the severe most being tracheal stenosis and the speech and swallowing impairment that is associated with long-term pediatric tracheostomy. So if you consider the globe as a stable landmark here and think that the structures around the globe are deficient, right? And that is what you need to normalize, that you need to bring the frontal bone forward and the mid-face forward. And then in comparison, the globe comes into relatively normal position. Now this improves aesthetics, and at the same time it improves function, which includes the airway and neurological improvement as well. So the question is, what is a safe age to do mid-phase distraction so that we can avoid tracheostomy? Which is the best way to perform it in a cost-effective manner, and how do you sequence it with other cranial procedures? This is the article which was published by Phil Pepelron in 2014 in Child Nervous System, where he has reported 22 patients from 1997 to 2012, where they have utilized transfacial pin distraction. And what they specified is that there was no maxillary distraction protocol. But he stated that the procedure is simple and fast, and the frame is easily inserted and removed, less distressing than the halo frame. And he was considerate enough to demonstrate it to us once when he came over. So here I'm going to discuss our 30 cases that we have performed in the last 6 years using transfacial of mid-phase distraction. The most common indications were obstructive sleep apnea and ocular and recurrent lower respiratory tract infections. The lowest age at distraction was 4 months. Most common diagnosis was Crouzon, as we all know, Crouzon is more severe among the spectrum. 3 procedures, the distraction procedures, were done using monoblock internal distraction procedures, and the remaining 17 were done using transfacial pin distractions. Now, this is a short video of how robotic assistance is utilized in such young children when we have to do transfacial pin distraction. This is a young girl. I think she was 7 or 8 months old when she came to us, and that's the trajectory which is planned using ROSA, which is a neurorobot. As I said, this is a off-label application. You can see that try to avoid the tooth buds, stay within the nasal cavity, and avoid the orbit. So this trajectory is planned on the software. And that is and we try to get the maximum possible purchase. You can see that the the space that is available for putting the pin, getting a purchase is very, very minimal. So carefully the frame is positioned for registration, and once the registration is done, the robotic arm positions itself into the predetermined trajectory. So there is a drill guide which will let you pass the pin in the same trajectory that you have planned. So once the pin is passed, the Lefort 3 osteotomy is performed. It's a subcranial Lefort 3, which is done through small facial incisions, lateral brow and midline nasal. Zygomatic osteotomy is completed through the lateral brow incision. Midline is completed, and the pterygoid disjunction can be performed either from the top, like so, or it can be done intraorally. Most of the times it can be done from the top. In case you need to go from the through the oral cavity, a curved osteotomy is better. So that's checking to ensure the mobility of the zygoma. Remember that this is one piece. You know, you have to be very careful that the zygoma does not get disjuncted from the maxilla, right? So that's that side, that segment which is stable and which is mobilized. We use 3D models intraoperatively to help with the procedure. So that is the distractor, which is a linear distractor, cylinder and a rod on which the distractor runs. It has a foot plate, which is also indigenously manufactured. So the foot plate engages the skull. A small burr hole is made after determining the vector. A hook, which is a part of the foot plate, engages the skull there, and there is another foot plate that runs up, which can be screwed onto the cranium. So that's the distractor. Now, the distractor position was determined. Now the distractor is positioned. Once the vector is confirmed, and that is how it would close. Again, the distractor is inserted. And fixed to the cranium. I do not use self-drilling screws because they are sharp. Self-tapping screws work well, just like how we do it for posterior calvarial distractions. And that is the distractor in position and good vector. So this is the same girl who had undergone Lefort 3 distraction. She initially underwent posterior calvarial distraction. And at the time of the removal, we had placed distractor removal, we had placed the mid-phase distractor. So that's her after the mid-phase distraction. The globe has support, airway is good, and she's doing well. Concomitant fronto-orbital advancement and mid-phase distraction can be performed. Now, this is different from monoblock distraction. Here, the cranial advancement is done, and then the mid-phase distractor is positioned. So your FOA is already performed, right? All that we have to do is to ensure that you leave the anterior cranial base intact. This makes it a very stable, very safe procedure. So this is what I mentioned. As you can see here, the distractor is in place. So the front orbital advancement and the mid-phase distraction procedure can be done at the same time. That's her at the end of the distraction. This is another patient who has undergone similar procedure. He is an upward, but front orbital advancement along with the mid-phase distraction. A different scenario where internal distractors were used. We do not use internal distractors for two reasons. One, they are very expensive in the Indian setting. Two, using internal distractors in a young patient can lead to, as you can see the yellow arrows that point here, can lead to disjunction of the zygomatic bones from the maxilla, which leads to this kind of outcome where you get good support for the globe, but the midface or the maxilla remains there. So one part of your problem is solved. The globe orbit related issues is solved, but the airway issues that are caused by the midface protrusion can persist. And he had persistent airway issues for which at 8 years external distraction was performed. So these are our results. Mean age at the time of transfacial pin distraction was 13 months, which is 1 year, 1 month, with a range of 4 months to 36 months. Mean age at the time of internal distraction was 26 months. Mean age at the time of external red distraction was 11 years. The amount of distraction achieved with transfacial pin is almost the same as what we can achieve with red or other internal distractors. So we conducted a subjective patient-reported outcome analysis, where we asked the parents about their children regarding snoring, frequent awakening, respiratory distress, any frequent of antibiotic usage, pneumonia, hospitalization, eye closure, any further history of globe subluxation, visual status, headache, vomiting, seizures, and general performance. So 8% of the patients still had. Now, these are what the parents have observed and what they reported. It's a subjective analysis, but 92% of the patients did not have frequent awakening. 61% had no snoring, and in 31% there is partial snoring. Now, this 31% of the patients are the older children, where the mandible growth and is catching up, and the midface still is protruded. So it's a relapse of the symptoms that you see, but which is expected as the child grows. Upper respiratory tract infections, cough, usage of antibiotics, there were none in 75% of patients, but about 25% of the patients reported it was. 92% of the patients had no further frequent hospitalizations or pneumonia. Nobody had airway, 92% did not have respiratory distress. 92% did not have globe subluxation. There was one patient who had incomplete distraction on one side due to device failure. So that patient had globe subluxation later on. No history of headache, vomiting, seizures, but this is a combined data including all the cranial procedures as well. And in general performance, you will see that 67% of the patients were doing very good, and 33% of the patients were doing good, but all of them have improved. Complications, zygomatic suture disjunction. There were some vector discrepancies in the initial stages. Foot plate dislodgement, infection at pin site, and 3 patients had to be taken back to OR for revisiting osteotomies. There were no events of CSF leaks at all, and no visual issues. There was one morbidity in a patient who had a congenital tracheal sleeve. He had issues postoperatively in the ICU. Even though tracheostomy was performed later, he succumbed to his other issues. So what are the concerns of LE4-3 at a very young age? Multiple surgeries, cost of the devices in a setting like ours, where the parents are probably starting to make a living, and it is multiple surgeries, and the cost effectiveness is a problem. Technically more difficult, the disjunctions are difficult. The chances of disjunction of zygomatic maxillary suture with internal devices are there. So chances of incomplete outcome is very significant. So these are the concerns you would think about when you perform a LE4-3 distraction at a very young age. And of course, Dr. Arlene mentioned about mandibular hyperplasia. So only when you distract the midface and bring the cranium forward do you realize that the mandible is so deficient in this children. See, all of them, when you normalize the cranium and the midface in relation to the globe. Now the globe looks, the orbit looks okay, the globe looks okay, the frontal bone looks okay, midface looks okay, but look at where their mandible is. So if airway issue crops up again, then it is due to the mandible. And as Dr. Arlene has demonstrated in a case, there will be a need for mandibular distraction in such cases. We follow an algorithm which Dr. Suhas will explain in the next talk. So few observations. The goal of procedure is more functional than aesthetic. Protect the globe, prevent globe subluxations, avoid tracheostomy. Not only tracheostomy, if you do a tracheostomy, think about the logistic issues, the speech impairment, the swallowing issues. So if tracheostomy can be avoided at any cost, that is great. Better airway, more oxygenation, better neurocognitive development and growth. So the intent is to get the children to tide over the first 6 to 10 years of growth, at which point they probably would require additional adjunct procedures. So it is, I have stated that it is possible to safely perform distraction in very young children. Transfacial pin distraction is probably an ideal way to perform DO in a low socioeconomic setting. And it also allows sequencing multiple procedures, that it can be done at the time of this posterior distractor removal. It can be done along with frontorbital advancement, and it's a very versatile procedure. And the application of robot is just something, a tool that we have, and we thought it would be a good thing to do. You of course can do it without a robot. It's just that you have to be very careful. You may need multiple passes, especially in very young children. A robot is useful because you have probably the size of your thumbnail on either side. So a slight change in angulation and you may miss the bone on the other side. So it just lets us pass the transfacial in a very predictable manner in a single pass. Otherwise, transfacial pin distraction can be performed even without a robot. Thank you so much for your patient listening, and Suhas will explain about the algorithm in the next talk.
Thank you, Pramod. Next, I call upon Professor Dr. Suhas Udayakumaran. He is a professor and senior specialist in Division of Pediatric Neurosurgery and Craniofacial Surgery at Amrita Institute of Medical Sciences, Kochi. He'll be sharing his experience on. Actually, he'll be telling us how to, simplify the approach or to do an integrated algorithm for management of craniosynostosis, syndromic ones. Suhas.
Thank you, Deepak. Just trying to adjust my.
What a beautiful first slide.
Okay, let's look at the rest. Okay. So again, as Pramod mentioned, this is a contribution of the unit that I'm going to talk about. I think my screen is complete, isn't it?
Yes.
Okay. So now my colleagues have spoken about, my other colleagues and Pramod has spoken about various options that are available in these syndromic children, the various challenges. Now the next obvious question is how to put them together. So that's where the obvious answer comes in, to put in an algorithm so that we want to combine all these different presentations, the different surgeries and different units involved into one single workflow and an algorithm. So the objective to create an algorithm is to have an unambiguous interdisciplinary decision making and to have a workflow based on the current evidence to achieve the optimal quality of life in these children with craniofacial syndrome. So we'll look at 4 parameters: the clinical features, the multidimensional CT to look for the sutural involvement, the MRI to look for the hydrocephalus and the Chiari, the sleep study to look for the obstructive and the central, to differentiate between the obstructive and the central. And then we combine it with the 4 clinical parameters, that the raised ICP, the presence of airway issues, the ocular issues, the presence of aesthetic issues, and other issues. You will realize in our algorithm that it is basically an integration of all the craniofacial issues, meaning syndromic and non-syndromic, together into a single workflow. So we look at, as I said in the beginning itself, we look at the signs of raised ICP, we look at the airway involvement, we look at the aesthetic issues and the functional issues involved. And the different parameters that are used, MDCT, MRI, sleep study, and we put it together to combine, to put forward 4 questions. One, is raised ICP involved? Is the MRI showing Chiari and hydrocephalus along with raised ICP? Is aesthetics involved? If that is so, then we come up with posterior wall distraction osteogenesis like the Birmingham unit. If ICP and aesthetics only are involved, most probably we go ahead with frontorbital advancement, once in a while posterior wall distraction. Shunt and ETV are once in a while options. Very occasionally, as Dr. Jay mentioned, we use programmable. Whenever only airway and aesthetics are involved, airway and ocular usually go together, we use the mid-phase distraction primarily. And for other aesthetic issues and for other functional issues, the other kinds of surgeries come into play. So, so the workflow is top down from posterior distraction initially for the combination of symptoms I mentioned, and the rest according to the presentations. So this is our treatment workflow. We gently categorize these patients into 5 different categories. And in my later slides, I'll mention how we utilize these categories into the algorithm. So we have 5 categories. Again, as I mentioned, we integrate the syndromic and the non-syndromic together to create a single workflow. So we have 5 categories. The category 1 is a non-syndromic single sutural synostosis, where we have different and some other combined anomalies like hypertelorism with secondary to cranio-frontal nasal dysplasia, etc. Now, in this category 1, we use the MRI sleep study. Both of them are negative for any negative factors. Aesthetics are involved, so we use frontorbital advancement. Sometimes they may require hypertelorism correction. And the next category is category 2, where you have only ICP involvement, with or without hydrocephalus and Chiari on MRI. Sleep study might be depictive of central apnea. Then, and the aesthetic involvement is surely there. Here we use the posterior calvareal wall distraction with and subsequently frontorbital advancement is added. Shunt might come in between. Shunt or ETV might come in between. The third category is when you have the airway or the ocular issues without the ICP issues primarily, and of course the aesthetic issues are involved. So you have a sleep study which is positive. You have an airway which might not depict at least no evidence of Chiari or hydrocephalus. And in these children, you use an option of frontorbital advancement of the aesthetics and mid-phase distraction. You have category 4 where both ICP and airway are involved, ICP, airway, and ocular. So here, there might be a presence of hydrocephalus and Chiari. So, and a sleep study might show central and obstructive apnea, and aesthetics are involved. So you use an option of posterior calvareal wall distraction, frontorbital advancement, with or without shunt, and a mid-phase distraction. And the category 4 is a delayed presentation where you might not have any MRI signs. The sleep study might not be positive for any positive intentions. Aesthetics are of course involved. And the treatment modalities are usually problem specific. So this categorization is based on, as you see, the complexity varies from 1 to 5, and the treatment workflow begins from the clinical features, MRI, sleep study onwards, aesthetics towards a surgical strategy. And if you notice, as the categorization changes from 1 to 5, the prognosis also changes. So I'll just go ahead with some illustrative situations now. So the first question as I mentioned, we ask for whether there's a signs of raised ICP. We look for airway and ocular signs, including failure to thrive, severe proptosis, exposure keratitis, and subluxations. So as I said, we basically integrate both syndromic and non-syndromic together to create a general workflow. So in the non-syndromic variety, we have what we would refer to as a geometric correction, where we look at the different discrepancies or in all dimensions and try to correct them as we go forward. I wouldn't go into these details, but just to illustrate. Now this is what we call as the geometric correction, where this is the plagiocephaly. We look at the discrepancies, and this is an example where the correction has been done on the right side. This is a metopic where the same technique has been used. Again, I'm gently deviating from the topic, but at the same time, remember that this is an algorithm which combines or integrates both the systems together. Again, a metopic corrected. This is a corrected metopic on the right side. This is a brachycephaly. On the right side is a corrected with the same version of technique. The right is a corrected child. According to us, we would put encephalocele and hypertelorism in the same category. That's the category 1 of our algorithm, where simple craniofacial anomalies and issues like hypertelorism and encephaloceles are put together for the management purpose. So this is a classical hypertelorism, where as neurosurgical, with a neurosurgical perspective, we would look at only the correction of the encephalocele. But if you look at in a wholesome way, we need to correct the hypertelorism too. So that's the hypertelorism in this child, a classical correction of the encephalocele along with a box craniotomy. So that's him in the post-op. So that's him after his correction of hypertelorism and encephalocele correction. So this is another illustrative situation where you have a older child with aesthetic issues alone, which we would put it in the category 1, where we are not bothered about the ICP or the airway. We only the aesthetics are issues. So this is our category 1, where we look at only the aesthetics. So this is a 15-year-old who has been corrected earlier, but now comes with gentle aesthetic issues only. So he has been corrected multiple times. So he has an element of plagiocephaly. So that's him on his profile. So he had a bone cement in the past. We have used hydroset to correct his, do an overlay correction to correct his deformity. That's a hydroset. There's a use of hydroset to correct the deformity. So that's him post-correction. Looking at, we have changes of his forehead, eye position, and in general, the aesthetics. So that's him after correction. That's him after correction. So this is another craniofacial anomaly called as a craniofrontal nasal dysplasia, where you have the hypertelorism along with the facial cleft, along with bicoronal synostosis, an excellent deformity. So that's here. He has he had a coronal synostosis and had the TCS cleft and the hypertelorism. So we did a box craniotomy for him. That's a box craniotomy for him, along with excision of the central portion of excess skin. So this is after correction. This is after correction. This is again a craniofrontal nasal dysplasia in a child with involvement of maxilla and mandible too. So here she has gone. We have done a facial bipartition where even the maxilla is used for the correction. So that's her post correction. Now our category 2 involves ICP and aesthetic issues. So here we, as my other colleagues, we would start off with the posterior calvar vault destruction, or nearly always, especially if that's hydrocephalus and raised ICP. Frontoorbital advancement is postponed during the later part of the infancy, and beyond that, other surgeries. So we have this is an illustrative situation where you have raised ICP only with no Chiarian hydrocephalus and no airway issues. So this is a complex scaphocephaly with the multi-sutural involvement. So that's multiple sutures are involved with a dolichocephalic shape. So his sagittal is involved, and lambdoid is involved on the other side, and the coronal is involved. So that's him. This is after correction, a complete cranial vault remodeling. That's after correction. That's after correction. This is at 1 year follow-up. So next situation is a revision correction for craniosynostosis when you have a raised ICP and aesthetic issues. So this is a child, an upper treated earlier in infancy and coming back to us after 5 years, at 5-year follow-up with papilledema. So you have this situation comes to us, belongs to category 2 for us. So we look at, of course, the aesthetic issues, but the papilledema is the primary decision maker. So this is at the revision cranioplasty. We do a frontal orbital advancement. Frontal orbital advancement. We have done his forehead. We're not corrected his maxilla, which will go ahead with, which will be done at a later part of the age because he had no airway issues at all. Again, PCVD can be an option. But being in the later age, we preferred FOA, frontal orbital advancement. So in the category 3, which is gently different from category 2, in that it does not have ICP issues. It has only airway and aesthetic issues. So we have an option of frontal orbital advancement and maxillary distraction. So this is a Cruzen with mild for cranial issues with minimal. I mean, he did not present with any ICP issues, but he had involvement of the face. Maxilla was involved, and he had severe airway issues. He had snoring. He had repeated URTI and LRTI. So we performed frontofacial advancement with using internal distractors. He had a combined surgery. So this is him after his post advancement of the frontal portion and the maxilla. This is an older child with airway issues and aesthetic issues. She did not have any ICP issues at all. So you can see the face, the orbits, the poor orbital floor, and the maxilla involved. So the classic situation, where we use the monoblock distraction. So this is a red distractor and the same kid. And that's the X-ray showing the advancement of the maxilla and the forehead. So that's her after surgery with the red distractors. So this is a classical situation where you have the airway involvement along with aesthetics, no ICPs, no clear signs of ICP issues. The next scenario is what we refer to as a category 4, where you have the ICP issues and airway issues, unlike category 2 and 3, where both are separate, and aesthetic issues, of course, are involved. So we have an option of using PCVD, posterior calvi voltage distraction, frontal orbital advancement, and maxillary distraction. This Pramod mentioned in his presentation too. This child presented at 11 months with a full fontanelle and of course airway issues. So we started off with you see the lambdoids are involved in this multidimensional MDCT and the gentle KRA. So we started off with a posterior calvial wall distraction, a classical technique as Dr. Girish mentioned, and the Birmingham unit does it. A similar technique, a single distractor, single telescopic distractor. Again, this is what we have achieved. Again, I won't go into all this. Now, again, this is what we have achieved after posterior wall distraction. Again, as Pramod mentioned, the robotic use of transmaxillary pins. The advantage is we have avoided tracheostomy in this. I mean, this for us, tracheostomy does not is not a part of our algorithm for now, unless except in one situation where we had to do it, but at the same time faced morbidity. So we don't do tracheostomy in our algorithm. So this child had an early frontofacial advancement with the Pellerin type distractor. So this is him after the frontofacial advancement. This is a situation where we had to use ETV and again posterior distractors. Again, this child we went on to do the anterior frontal advancement and a maxillary distraction too. Just an illustrative example, not to go ahead with that again, as Dr. Jay mentioned, programmation is an option in these hydrocephalus. The next situation is where you have an ICP and airway issue in an older child. So that the earlier two instances were in an infant. This is an older. This is a different scenario where you have ICP, airway, and aesthetic issues in an older child. So this is again an older child with airway and ICP issues. So these are the different options which we have classically. Again, he went on to have an internal distraction of frontofacial, a classical frontofacial. This is what we achieved in him. As Pramod mentioned in his talk, the maxilla was suboptimal, but he went on to have a better airway, reduced airway symptoms, and later he had a revision surgery. So for us, the category 5 is a delayed presentation, as I mentioned, and here we address only the specific issues. Like this example, this is a 17-year-old untreated cruiser who came to us with severe neck pain and an MRI showing the syrinx. So we did. She was 17-year-old. She had no other issues, only neck pain and syrinx. So we did not do a posterior wall distraction. Instead, we did only foramen decompression, and she improved after that. This is a 15-year-old and untreated upwards. He came to us with only aesthetic issues. So he went on to have a red distraction. He did not have ICP issues. Of course, his performance was affected, but at the same time, his only need was aesthetics. He was 15, and so we addressed only his aesthetic issues with a red distractor. That's what we have achieved in him. So in these kinds of delayed presentation, which we refer to as the category 5, we we address only the specific issues. So that's him after surgery. So as others mentioned, we have a similar line of evaluation protocol. Nearly similar line of management, except that we use mid-phase very early in life, because we believe that the functional improvement offered by mid-phase cannot be neglected, and probably we avoid tracheostomy. And I think most of the neurosurgeons or a perspective is always there that probably the airway is not a very important issue, which is probably a poorly understood aspect. The amount of damage that the hypoxia or hypoxia causes is probably underestimated. So to conclude, we have demonstrated a tailored presentation-based approach, and we propose an unambiguous interdisciplinary decision-making and workflow to bring together all the different perspectives and specialties together. Thank you.
Hi, thank you, Suhas, for a wonderful presentation to wind up the series of presentations.
Thank you.
I think we'll have a very short and quick discussion. We'll just go ahead and present a very short case to you, because we have talked so far about surgeries in craniosynostosis, but I'm sure you will sometime in your life you must have come across cases wherein you have to decide whether to operate or not to operate these cases. So this is one case I recently came across in my practice, and I would seek opinion of the panelist and the house, what should have been the correct approach. So this was a 3.5-year-old girl child who presented to us with abnormal head shape, delayed milestones, growth retardation, and proptosis. And yes, she had a history of recurrent sore throat, chest infections since birth. In fact, we had to admit and then discharge her back because she had some LRTI. And this is how she looked grossly normal, I would say, when she presented. But over a period of time, her deformity started worsening and she started having a tetracephaly or a towering kind of circumference. This is the workup which we did for this girl. I mean, she had delayed both cognitive and motor developmental. The quotient was pretty low as for the age. And she had a depressed nasal bridge, as you must have seen in the previous picture. However, the ENT evaluation was grossly normal. The ophthal evaluation on the OCT revealed evidence of bilateral foveal thinning, suggestive of optic atrophy. And she did have some cardiac anomalies, like she had a small atrial septal defect with a shunting from the left to the right. She had some mild AR and moderate mitral regurgitation. However, the EF was pretty normal. HRCT chest revealed evidence of pectus craniatum, and she had some linear atelectasis in the right upper lobe with a small airway disease. If you look at the X-ray chest here, the trachea is shifted on the right side. There is some cardiomegaly is visible. And we did her, our geneticists from our institute, they did the workup, and the enzymatic assay had findings, the raised aryl alpha sulfatase and hexosaminidase levels suggestive of mucolipidosis. It's a kind of a lysosomal storage disorder. I'm sure many of us know about it. And so This is a polysomnographic study which we did in the child, and she did have plenty of episodes of hypoapnea there, and and this is the preoperative CT scan, and you can see there were changes suggestive of raised pressure. This is the VRT images for the child, and yeah. And this is the MRI, and on the right side you see the MR venogram. I usually don't do CT venograms. I usually do MR venograms in my cases. Now the question is, you have this 3.5-year-old child who has some cardiac changes, and she has got a lysosomal storage disorder, which itself has got a not a very great prognosis, to my understanding. What should have been the approach in such a case? I would like to seek opinion of the house before I tell what we did.
Let's start with Girish.
Okay, so that's an amazing case. My God. I think I'm glad that I didn't get to see this case, but yeah, it's a lysosomal storage disorder. I think the other name for it is ICEL.
Yes.
It's extremely rare. You can get this sort of quite significant cranial synostosis very, very early. Because of the lysosomal storage disorder, I think they is exosimidase, and you end up getting skeletal dysplasias as well. So they, I don't know if you did a skeletal survey on this kid.
Yes, we did, and we had many.
Any specific? I think they will get vertebral anomalies and rib cage and pectus carinatum and other things. So you get respiratory problems as well. I can't remember. I wasn't. Did you do a tracheostomy on this child?
That is yet to come.
Right.
We're talking about the decision to operate or to do nothing for the child.
Yeah, so they get tracheomalacia as well. But the great difficulty here is what to do because of the significant vascular hypertension you indicated. So, can you show the MRI scan again? I didn't think the hydrocephalus was severe, but yeah, so I didn't think the hydrocephalus was severe enough to require immediate sort of decompression, but clearly there is severe deformation of the skull, which is going to require treatment. Vision, was there a problem with vision?
She had primary optic atrophy. The child had vision, but it could not be adequately assessed.
Yeah, I mean, I think with the amount of bone erosion, I would definitely consider doing some sort of a general calvarial release. It doesn't have to be a distraction. You can just loosen up the bone, just like the type that we do with Pfeiffer's and Klebat shuttle, because you want to do a smaller procedure as possible and get out of there, because these children don't tolerate surgery very well. And they can have cardiac abnormalities as well, cardiorespiratory abnormalities.
Is Dr. Erlin there?
I'm sorry, were you talking to me?
Yes.
Okay, so yes, looking at that skull defect, just as the previous commentator said, I would probably go in and just release this area on the back that's severely depressed and do some frontoorbital advancement with taking all precautions. And then you said she had a lot of hypopneas on her sleep study?
Yes.
Do you remember what the AHI was?
3.5 years.
How much?
No, I don't have those figures with me, but they were definite episodes. I don't have the index level. With
Okay,
me,
so her maxilla does not look severely retruded there. So we would do a sleep nasoendoscopy to see if she was obstructing at the tongue base level. It also looks like she's got a depressed nasal bridge, so she might have obstruction at the nasal level. So we'd have to evaluate that and see if there was anything indicated for that. But regarding her calvarium, I would do, like the previous speaker said, a one stage, just open the area up, advance the back and the front.
Anybody in favor of no surgery for the child? Nothing to be done for the child?
I'm a favor to no surgery, Deepak. It's a fatal condition, and maybe I will do watching. So I think that it's no benefit, I think.
I suppose you could discuss with the parents, because this is actually an autosomal recessive disorder. We have not had a case like this, to be honest, and I'm glad we didn't have it. But I remember that Suchanda Bhattacharya, I don't know if she's on the on the panel. She had a case. I remember that because although they didn't operate because the parents refused surgery, but Suchanda had a case like this, and she's in Hyderabad. Is that right? We could, if she was, or Manas might know. But yeah, so Ricardo, I don't disagree that you may discuss with the parents, and the parents may choose to do nothing. But if she's having hypopneas and apneas, there is, and looking at the skull with significant dorsal compression, I would have thought that, you know, the simplest thing you could do is just release the bones. But of course, there's nothing simple about this. So, yeah.
So yeah, I mean, I mean, after detailed counseling with the family, the mother, they badly wanted to have surgery, and we thought, okay, fine, with explained prognosis to the parents. And we did go ahead with the plan to do the surgery as rightly suggested by the panelists. However, intraoperatively, perioperatively, our anesthetists, they could not intubate the child. There was no tracheomalacia to my knowledge. We had done a CT chest and neck also prior. It looked pretty decent, but somehow the intubation was just not possible. In our institute, it probably happens once in every probably 1 or 2 years when our anesthetists, neuroanesthetists are not able to intubate because they are par excellence. Anyhow, so we went ahead with the tracheostomy for the child on the table. And so again, I was in a fix, you know, whether like a child with such a dismal, gloomy prognosis, you know, wherein you don't even have adequate airway access, whether to abort the procedure and reverse the child and, you know, or to do nothing, or to go ahead with the surgical procedure. So yes, I did go ahead with the FOA plus CVR in the child. And this is how the skull looks like. We could attain a pretty decent amount of decompression, the advancement, as you can see here. This is the pre-op on the left side, there's a post-op on the right side. And I went as much back as possible. These are the images from the side. So post-operatively, the child remained E4, V tracheostomy, M spontaneous, the vital stable. And but the only problem that stayed with the child, you know, like she had evidence of kind of consolidation, ARDS, and ventilator dependence. And it's been almost a month and a half. And these are serial X-rays. She had this very small wound issue, which was managed well. But she's still on ventilator support. And I would say she's almost ventilator dependent as of today. So this just brings me to this basic question, you know, like in spinal dysrhythmism, we often talk about this low burst approach, few cases which we should not operate. So probably, I think a surgeon, most of the time in our country, the parents, they accept what we tell them to more or less to, you know, reasonable extent, kind of acceptance. So probably, I think it's a call that needs to be taken by the surgeon in a child with such gloomy outcome, with cardiac anomalies and other multiple issues, and wherein we could not even have an airway access in the child adequately. Are we really justifying doing this procedure? What are we gaining out of it? So that was the whole idea of presenting this case. I'm open to discussion and criticisms.
Deepak, I think I would agree with what Dr. Ricardo and Dr. Girish said. We've had 1 or 2 cases who came and we have explained the gloomy prognosis, and most of the time the parents are okay with it. I mean, when the average life expectancy is so low, I mean, are we justified in doing it? A second thing I want to ask, would just a tracheostomy been enough and just leave him? Why do all the entire FOA and all that?
Yeah, I talked about it. In like my three options were just to do a tracheostomy and do nothing. In fact, probably we could have just reversed the child. When the anesthetist was not able to access it. I could have just reversed the child and sent back home. So
I mean, that's what I was about to say, Deepak.
Yeah,
I would have just stopped at that point. If you can't get a proper tube in, you can never be sure how you're going to proceed with such a major undertaking. I would have stopped. I would have just, and one thing, I would never do this case in anything other than supine. Do the bare minimum, do just as little as possible. Perhaps just take out the lateral panels, handle them and put them back. Try to do the bare minimum and walk away. Try and make the procedure as simple as possible.
No, what is the bare minimum?
I would have just taken the lateral panels. If they would have been able to get the tube down, I would have done it in supine because she had a left to right shunt, if I'm not mistaken. There was a left to right shunt, which means if you do it in any position, there is a high risk of air embolism. So I would have done it in supine position. I would have got the patient well filled up all the time, make sure that the anesthetists are on board to make sure that they don't keep the child, properly filled up all the time. I would have done, all I would have done is bare minimum, done the case right from skin myself. No trainees involved here, I'm afraid. I would have just taken out wide lateral panels, handled them, just let them float on either side and walked away.
So intra we had no issues. I mean, surgically it went well. And the problem is the disease itself. Because of this lysosomal storage disorder, these children are very highly prone to infections. And they keep on having these bouts of LRTIs, and that's one of the reasons. Probably, maybe I'm able to send her back home after a month or two from now, but she's still with us. So that
we had one or two such cases as well, and very difficult.
Yeah,
I think, Deepak, the problem is, you asked about, what we do in India, with the enormous population and limited resources. The parents sometimes, have to travel long distances. The contrast is, for example, in the UK, is parents can often be, well informed. They may have planned this pregnancy. This may be their only precious child, and they don't particularly care if the child has lysosomal storage disorder. They see it in a very different way. And I've had to contend with this issue about, what is the ethics of operating on children who may have very limited lifespan, or lifespan filled with surgery after surgery after surgery. And you just think that, that you are putting a child through a cruel life of operation after operation in the hospital. But, some of these parents are very, pro-life. They would want you to do everything possible. So I think it's, you can't, I would leave that as an unanswered question, to be honest. Because the factors that contribute to that decision sometimes not in your hands. But I think, and Ajay, I think you've made some very important points. Supine, definitely. I would say, if you're going to do this surgery, somebody with pectus carinatum or other skeletal disturbances, the airway is often compromised already with the trachea. Putting them prone is a real challenge for the anesthetist, for you. If that tube slips out, you're in real trouble. So I think Ajay has pointed out a very important point here. Do it supine. So I think in future, if you get a chance, if you have to do a case like this, and you can, you don't have to go all the way into foramen magnum. So in a supine position, you can still do a good calvareal decompression. But once you start operating and things are going well, then you'll end up doing more than you planned. So again, I don't sort of, I think, you did good. That's the way I would put it. And the child as well. So
from the supine only.
All that ends well, ends well.
Thank you.
Yeah.
Dr.
We had a
Deepak?
similar case not long back here where they tried to do everything. They had a lot of problems in the beginning, and then they managed to start the case, and then everything was going fine until the very end, and then the lactate started shooting up. And for some reason, the child didn't wake up. They kept cursing themselves. We should have stopped. And even I walked into theater and I said, guys, don't overstep your mark. You may get into trouble. And if anesthetists get into this false sense of everything is going fine, go ahead. And the surgeons, you tend to try and do the maximum in one go. I think we should resist that temptation in difficult children.
Okay. Dr.
Dr. Deepak?
Yes.
Can I make just a comment? And this child had a global medical issue, and she had ongoing lung issues. So that may have been something you couldn't avoid, no matter what was done. But just from an airway point of view, again, I understand she's a very difficult airway. They probably couldn't visualize the larynx.
Yes.
And so on those kids, we actually use a fiber optic scope and intubate them over the fiber optic scope. But then again, in her, she's still going to have airway obstruction probably post-op. And so then when you go to extubate her, you have to have a plan in place already to maintain her airway possible. We always have nasopharyngeal tubes at the bedside. We have oral airways at bedside. I often put a tongue stitch in the kid. So if they do start obstructing, you can pull it forward immediately. And we have an LMA at the bedside ready to place in case of ongoing airway obstruction. But that wasn't the only issue here in this kid. She has global metabolic issue. So
yeah, they had attempted, or they had fiber optic, and we have everything. Our neuro anesthesia department is probably par excellence. They had tried everything, and almost 30 to 45 minutes was tried, and they just could not do it. And it was very surprising to me that they could not intubate the child, and it was once in a lifetime kind of a case. So next, I would just ask one question to Dr. Arlene about her, this Sanchez little smiles. What is this activity like? I saw it in your CV. You do some social cause.
Okay. Well, here in Detroit, we are we're very into sports. And we have, you may not know this, but we have the Detroit Tigers, which is a baseball team. We have the hockey team, and we have a football team, the Lions. And Sanchez was one of the pitchers for the Detroit Tigers. And he and his wife had a little charity where once a year, he would invite me and some of my little patients and their families up to his private box at Tiger Stadium to watch a baseball game with, a full meal and entertainment and so on and so forth. So
awesome. Dr. Suresh?
That's fine. That has been a wonderful discussion, and your case which you showed really was very, very interesting. And as Girish said, some of the time you don't have the answers for everything, and this is probably one of that situation. I think we have very good discussion and a very good program today. And
sir, if you don't mind, can I just ask a small doubt?
Yeah, sure. Please go ahead.
This is to all the panelists. How many of you use adrenaline along with niclocaine for infiltration of the scalp before incision? We had a very bad experience with adrenaline, and it was taken into the scalp veins because his veins are generally thick and infiltration is a blind procedure. And BP suddenly shot up. Patient had a ICH. So I was just wondering how many of you use adrenaline. After that, I've stopped using adrenaline completely.
I don't use it at all in children.
Oh.
Only Chirocaine, and also at the end of the surgery, never at the beginning.
In craniofacial,
I use it for all cases. Chirocaine with adrenaline. I've used it from day one. Actually, I've never had a problem for any of these cases.
We had this because that whole thing was blind, and venous sinuses are quite big. So,
in craniofacial surgery at Birmingham Children's, we don't use it. But I know that some other centers do use. So, Ajay, do you use it for craniofacial?
Every case. Every craniofacial case. I never had a problem. Yeah. I think it just shows that, don't change your practice for one case.
No, but then actually it didn't make much of a difference regarding the blood loss. It didn't make much. So
then you stop using
about 120 major cases a year, or in another 30, 40 minimal cases. Practically every case getting Chirocaine. I mean, we haven't got away. Maybe next time we might be the one who may come and tell you.
Great Ormond Street has published a paper. They designed a potion which contains hyaluronidase and a few other things in a Hartmann saline. And what they do is they inject the scalp with this solution. and it just makes it easier to do a scalp.
Tumescent.
Yeah, as a hemostatic
Tumescent,
agent,
yeah,
but
yeah.
it makes it easier to lift the scalp. And if I remember correctly, it contains a small amount of adrenaline.
Yeah, it's called the Tumescent. Yeah, we use it.
That's right.
Nothing better than adrenaline. It just makes life so much easy.
I have to disagree. I am very worried about using adrenaline. I have one child that had a very similar experience. With children with venous hypertension, you can accidentally inject adrenaline in them.
Why should you inject accidentally if you're careful? How would you? If you don't.
Because sometimes you're not careful.
Yes. Well, then you answered my question.
Ajay, accidents happen.
Yeah, exactly.
Absolutely, it does happen.
Has it happened to you, Dr.
Yeah, it did. I mean, it was really bad. But somehow we came out of it, but that set me wondering, and then we stopped using it. Didn't make much of a difference finally at the end of it. So good.
Do all of you use cell saver in your practice while doing these cases? The big ones, pediatric cell saver. Anybody?
Yes, we do use in Birmingham Children's always routinely.
Okay.
Yeah, for all major transcranial cases, cell saver. It's just a matter.
And somebody asked about tranexamic acid as well. So that's something that we use as well.
I think
so what we found with cell saver is that it doesn't stop you from giving a transfusion. What it stops is from having more than one donor exposure. So in other words, in a case where you might have perhaps needed another bag of blood, that element is taken off. And in older children, perhaps you get away with no blood transfusion. But in the younger ones, where you're doing a major frontal orbital, you may just get away with one donor exposure when you use cell saver.
I heard Dr. James Rutka I think last week only. He talked about his experience of cell saver in a child with hemispherotomy. What he said was probably during the hemispherotomy procedure, it releases a lot of thromboplastins, and they go in the cell saver. And his child, when the blood was transfused back to the child, went into massive DIC.
So, right. Okay.
Yeah. So that is something he says. Hemispherotomies, we never intraparenchymal procedures.
Right. Okay.
They don't use it at all.
I mean, I've generally not used it for tumors. I have used, barring one case, when I was doing a huge juvenile angiofibroma, which was going everywhere into the cavernous sinus everywhere. In that case, I used cell saver, and that's the only one I can recall in tumors which I have used. But JNAs are not generally, they don't tend to cause problems with metastasis.
But the guidelines now is if you're doing a benign tumor or if you're doing a bone tumor, you can still use a cell saver.
Yep.
Because the cell saver, I think it's something like 5 micron. So most of the cells would be blocked by that. So there is some evidence, just like Professor Rutka said, we've had one case where during excessive bleeding, some of the flow seal created some difficulties, like an embolus. But I've not heard of that happening with the cell saver because again, the 5 micron filter would be unlikely to allow anything to go through.
Yeah.
What do you think, does it?
Exactly. And you don't even need to have a cell saver to cause that problem. You can even go into the normal veins, because orthopods got into trouble with when they were doing scoliosis surgery. They're using a lot of hemostatic agents, and they managed to, they were using 2 hands, big blobs of flow seal, and managed to cause an embolism. And
I suspect that's probably what happened with Professor Rutka.
Yeah.
I think the cell saver can't be blamed for that. It will be very unlikely. What do you think, Desi?
No, I agree. We use it. We say that it does not allow particles to go through. So I'm sure that whoever has used it has used it at force in a vein which was open.
Exactly. That's
we had one of our case in our hospital where it caused a embolism.
Yeah.
Once again, these are things one has to really take with a pinch of salt, and don't change, especially for youngsters in the audience, don't change your practice for just one case or one, hearsay from somebody. Don't change your practice. There are a lot of little things that.
Absolutely right.
Dr. Arlene, do you use cell saver in your practice?
No, we don't. We try to be we try to maintain hemostasis as we're working. We do try to keep the kids relatively low blood pressure, and we do give them TXA, tranexamic acid. And we try to keep the room warm. I think for most babies, we do think that we're going to give at least a half unit of blood. We split the unit so that if they get the half unit during surgery, at least they're not getting exposed to another donor later on if we have to give a little more blood later on. But it's very unusual to have to give any more blood after we leave the OR. And the other thing we're very careful about is we just don't keep giving a lot of packed red cells. When they get a certain volume of red cells, you know you're going to get hemodilution and you can get a coagulopathy. So we start giving them fresh frozen, and we follow the platelets very closely too. So we make sure we're not just having a downward spiral of getting into coagulopathy and the bleeding gets worse. And when we've managed it that way, usually we only end up giving half a unit of packed cells.
And Ricardo, do you do it?
No, Gish, I don't use cell savers. I saw this when I was in the care. They at that time they used this. I don't know today, but currently if they still using this, but I don't use. I do the meticulous massage during the opening the skin, protect with what can I say, the honey clips, the skin. That way, I don't use the cell saver.
I picked up the cell saver technique from Necker as well, just like you. And then when I came back to Birmingham, we started using it. Yeah. What about erythropoietin? Does anybody use erythropoietin prior to surgery?
I don't.
We have used it very sparingly in 1 or 2 cases where the hemoglobin has been very low, and those for very specific indications when they have certain problem with the RBC production. So we have used it for 1 or 2 cases, but super selective. We generally tend to check the serum ferritin level and optimize the iron, levels prior to surgery. And but we've used erythropoietin maybe half a dozen times, or maybe less than that, once in a while.
Excellent.
I think we should call it a day.
Yeah, we should call it a day and wish good luck to each other, because the way things are going on.
Yeah, take care, guys.
I don't know what's happening in US and Brazil, but we are really almost burnt out to the core, we are getting almost 400,000 cases a day, which is a big number. And these are the visible cases, there must be 3 to 4 times cases which are not visible, so-called asymptomatic. So I would say it's something like, it's a huge number. 2 million cases approximately should be happening every day in our country. And luckily, we are not having that much mortality, I would say. The vaccination drive is kind of going on pretty decent. Almost 150 million have been vaccinated in our country. How is it like in, the last question from me to Aline, how is it like in US and Ricardo in Brazil?
Brazil, yeah.
Well, in the US, things were under control until spring break occurred, where all the kids get off of college and school and they went traveling and got exposed to a lot of people. So we had a surge for the last 2 weeks, but now it's leveling off again. And I believe it's close. We have a population of about 350 million, approximately 150 million have gotten at least a first vaccine so far. So they're hoping that the next step will be now the kids will be able to get vaccinated, kids 16 and under, so that hopefully they'll be able to go back to school in the fall.
Any trials done in US? Because I have gone through everything. I think under 16, there is no trial. Anything ongoing?
There's no what? I'm sorry.
Any ongoing trial on the kids under 16?
Yes, they are. And it's looking very good. So I'm thinking within the next month, they're going to allow, they've already approved it down to 12 years old. And I'm thinking within the next month or 2, they're going to approve it right down to all the school age kids.
Awesome. Ricardo?
Yeah, there are trials going on in this country as well for children 12 and above, but they haven't published the results yet.
And they are not planning to cover that population.
At the moment, no. I think they've just, in this country, they've just reduced the age down to 40, if I'm not mistaken. They're still up to 40 in. I mean, you have to vaccinate 80,000 40-year-olds to save one life. That's the rough statistics. Unless you got serious pre-morbid illnesses. Compared to just vaccinating 20 80-year-olds to save one life. So it's just pure maths. You know, you can avoid spread of infection by vaccinating the young, but there won't be much of an influence on hospitalization and deaths. So
In
it's
India, I
more,
think they're starting 18 and above from tomorrow.
I think if they can get the 40 plus vaccinated, which itself will be about 500 million, that they have done a good job.
I'm pushing hard.
I think Mumbai is showing some stability, so that is a little bit of good news. And probably if Mumbai starts coming down, then we have some hope for the rest of the country. I mean, the rate will eventually come down. That's what I mean.
Right now it is Delhi and UP and nearby.
I think the other thing good which US has done is about this pregnant women. You know, they have I think vaccinated over 95,000. The Be Safe registry which I went through. But I'm trying to push my government here to start vaccination for the pregnant and the lactating women. Unfortunately, most of the studies are available with the mRNA vaccines only, the Pfizer one. You know, because we have this inactivated virus, which looks pretty safe, I would say, because the pregnant women, they do receive inactivated viral vaccine per se. So I did submit my request to the higher authorities. So hopefully that group will be included. But nice, Dr. Eileen just talked to me about the kids 12 years and above. And if there's something available on the net or you know on the CD on the web page of the NIH or something, please do share it with me for the younger population. I would rather take the matter further to my government if there's something.
Yeah. Thanks, right? And a good night, everyone.
I think.
Yeah, good night.
Good night. So thank you very much, esteemed faculty, for joining.
Thank you so much.
Thank you so much. We will meet next month, and next month's webinar will be on pineal region tumors. It will be on 28th of May. So hopefully to see some of you. Thank you very much. Good night.
Thank you.
Good night.
Thank you very much for organizing this meeting.
And thank you to Mr. Jagrup from Intas, for sponsoring this meeting. Thank you.
Thank you, sir. Good evening.
Thanks for organizing.
Thank you.
Good job.
Bye bye.